Okay, so in this session, the crash course, the topics will cover thyroid, parathyroid, adrenal, Men's syndrome, and urology. Okay, in urology, we'll cover kidney, ureters, urinary bladder, prostate, urethra, testis. Okay, so these are the topics we'll be covering in the next 5 hours. Okay, so as this is a crash course, so we will basically focus mainly on those points, those topics which are high yield topics and where the probability of getting the question in your exams, be it INICT or NEET PG, the chances from these topics are very high. Okay, so the screen, the chat box is open right in front of me. So any kind of question, anything, you can write and we can discuss those things. If there is any controversy, there is confusion regarding any topic which you have already read, you can ask me those things also, we can discuss. Okay, so thyroid. The first thing in the thyroid we'll see is in the congenital anomalies. Okay, the most important thing which you are supposed to know is thyroglossal cyst. Okay, there are lots of questions on thyroglossal cyst. So thyroglossal cyst occurs because of, suppose this is tongue, and during the development of the thyroid starts developing from posterior aspect of the tongue, which is known as foramen cecum, and then it comes down to its normal position via a tract that is known as thyroglossal tract or thyroglossal duct. So this thyroglossal tract, normally it disappears in around 7 to 8 weeks. Yes, oral malignancy also is there. Okay, oral cancer and also something about salivary glands. Yes, Anuj, that also we'll discuss. Okay, thyroglossal tract. So normally it disappears. If it persists, then over the period of few years there will be a cyst present that is known as thyroglossal cyst. Okay, there will be mucus collection and there will be thyroglossal cyst, and mostly this thyroglossal cyst is present just below the hyoid bone. Just below the hyoid bone. So the most common location is subhyoid. Subhyoid. So the lining of this cyst is pseudostratified ciliated columnar epithelium. Pseudostratified ciliated columnar epithelium. And we all know the presentation. The presentation is a midline swelling, midline neck swelling, which moves with deglutition as well as protrusion of tongue. Okay, so this you need to remember, protrusion of tongue. And another thing you need to remember is as a complication, if you don't do the surgery of thyroglossal cyst, so in the long run there is increased risk of papillary thyroid cancer. Papillary thyroid cancer in the long run. So there is increased risk of this malignancy if you don't do the surgery. Okay. So what is the treatment? Damsonia, nothing much is done. This is where we have started thyroid. Okay, we are talking about thyroglossal cyst. Okay, treatment is, see in this part only we'll see, we have to remove this cyst along with the whole thyroglossal tract. So in order to remove this, we might have to take a part of the hyoid bone The name of the surgery is cyst trunk surgery. Cyst trunk surgery, where we'll remove the thyroglossal tract, thyroglossal cyst, and a central part of hyoid bone. A part of hyoid bone. Okay, so this is cyst trunk surgery. Okay, one more thing we'll see, lingual thyroid. Okay, this is a condition where there is ectopic thyroid tissue present at this foramen cecum at the posterior part of the tongue. Okay, thyroid tissue in the posterior part of the tongue. So normally it does not cause any problem, but if it enlarges in size, okay, if it enlarges in size, then it can cause problem like it can cause dysphagia, dyspnea, change in voice. Okay, so that time when you talk about the treatment of this, if you talk about the treatment of this, treatment is either you do ablation, okay, radioactive iodine ablation, or you can go for surgical removal. Okay, so the only question which they ask in this case is that if you are planning a surgical excision of this part, then before surgery, get a radioiodine scan. Okay, radioiodine scan is done to see that whether there is any other thyroid tissue, thyroid swelling present in the patient's body, or this is the only thyroid swelling. Because if this is the only thyroid swelling present and you are going to remove this, then you need to tell the patient beforehand that after removing of this, there will be a, the patient has to take lifelong thyroxine supplementation. Okay, so the patient should know that after the surgery whether he has to do anything special or not. So this you need to tell. But suppose the patient is having a normal thyroid and this thyroid also, then you can very well take it out without, without having this problem of lifelong medication. Okay, next important thing we will see in thyroid, very important. There are high chances you will get one question from this part which we are going to do. Solitary thyroid nodule. Solitary thyroid nodule, STN. The meaning of this solitary thyroid nodule is that in the thyroid gland there is a single palpable nodule present. Okay, one nodule in the thyroid gland. Now this nodule could be anything. This could be a cyst, this could be a it could be a cancer, it could be a benign tumor. So if we see a differential diagnosis, this could be a benign tumor which is mainly known as colloid goiter. Okay, Palak, not much has been done. I'll show you that part which we have covered, the congenital anomalies of the thyroid, thyroglossal cyst and lingual thyroid. Okay, just this much part. You continue from here, and in the break, when we take it, we'll take just one break after we finish this part before we start the urology. That time I'll show you those things which you have covered. Okay, so colloid goiter is the most common differential. Then it could be a follicular adenoma. That is also a benign tumor. It could be a malignancy. It could be a thyroiditis. It could be a cyst. It could be a metastasis from some other tumor. Okay, so any of these is the possibility. So when a patient comes with this type of swelling in the thyroid, we have to do the investigations and accordingly we have to treat the patient in solitary thyroid nodule. Okay, so let's see how we are supposed to go in this solitary thyroid nodule. So the first thing you will do is you will take the history and do the clinical examination. Do all the examination, find out if there is any enlarged lymph node, what is the size of the nodule, whether it is really from the thyroid or from some other area. So if it is moving with the deglutition, you'll know that yes, it is arising from the thyroid. Then the first investigation which you will do is the thyroid profile, T3, T4 and TSH. So this is the first investigation. Now when you do this, you will know there are two types of patient. You can divide the patients into two groups. One patient which is hyperthyroid. Hyperthyroid means when the TSH will be low. And one group will be euthyroid or hypothyroid. Okay, when the TSH is in the normal range or it is high. Okay, so now we'll see what we are supposed to do if the patient is hyperthyroid. Okay, the speed, if I'm keeping this speed, I guess it will be fine. See, one advantage is that you will have the recorded version of this also. So if you miss anything while writing now, you can anytime you can go back in the recorded version and you can complete your notes. Hope this is fine. Okay, so in hyperthyroid patient, we'll go for radioiodine scan. In radioiodine scan, we'll give a radioisotope. Mostly we do in the oral form, iodine 121, 123 or technetium 99 pertechnate. All these are radioisotopes. Okay, mainly the diagnostic isotope is this 123. Okay, so when you give this radioisotope orally, so that radioisotope will be taken by the thyroid as well as it will be taken by the nodule. Okay, so there are three possibilities when you do this scan. One possibility is that the nodule has taken most of the radioisotope and gland has taken very minimal. So that type of nodule is known as hot nodule. Hot nodule. Yes, Ria, just remember that although in the exam many times they give the TSH values, but the normal TSH, just remember it will be, okay, I should write here. Normal TSH is 0.5 to 5 milli international unit per liter. 0.5 to 5 milli international unit per liter, that is a normal TSH value. So if anything more than 5 or 5.5, consider it as hypo. Anything less than 0.5, consider it as hyper. Okay, Ria. So this is hot nodule. Suppose the gland and the thyroid has taken equally, then it is a warm nodule. And suppose the gland has taken the radioisotope but the nodule has not taken, then it is a cold nodule. Okay, so these are the three possibilities after doing the radioiodine scan. So if it is a hot nodule, you will give either anti-thyroid drugs or you'll go for RAI ablation. Okay, in the ablation part, you will use iodine 131 isotope. Okay, this we'll discuss again when we will discuss the treatment of Graves' disease. Okay, if it is warm and cold, okay, warm or cold, then we'll treat it like we are treating these patients. Okay, so now you can write euthyroid, hypothyroid, or warm or cold of hyperthyroid. So now this is another arm. This is one arm, that is another arm. Okay, so in these patients where the thyroid is either normal or it is hypo or it is warm and cold type of hyper, in this group you will go for ultrasound neck. Ultrasound neck. So ultrasound neck will tell you the size, exact size. Okay, whether it is more than 1 centimeter or less than 1 centimeter. Okay, more than 1 or less than 1 centimeter. Now one important question you will see, just I'll write in the side, that there are certain features. Ultrasound is a very good investigation for the lymph nodes of the neck or for the thyroid. It is considered as as good as CT scan. Okay, so many times you don't need a CT scan for the thyroid disorders. So we'll write here what are the features suggestive of cancer on ultrasound. Warm and cold nodule is, in warm nodule, the nodule as well as the gland has taken equally. Okay, you can see the nodule has also taken and the gland has also taken. In cold nodule, the gland has taken, but this nodule has not taken anything. Okay, it has not taken the isotope. So that is the difference between warm and cold. In hot, the nodule will take most of the isotope. In cold, nodule will not take the isotope. In warm, it will take as compared to the rest of the gland. Okay, Nishant. So feature suggestive of cancer is if it is a hypoechoic. Okay, taller than wide. If there are microcalcifications. If it is a solid nodule. And if there is, you can say irregular shape. Or you can say asymmetry. That is a better thing. Asymmetry. Okay, so based on these features, I am sure in the breast you must have read about Biret score. So based on these features, there is a score in the thyroid also, ultrasound, that is known as Thyroid score. Okay, the details of this Thyroid is not required, but this is thyroid imaging reporting and data system. So based on this ultrasound finding, you can have suspicion that, okay, this type of nodule looks more malignant, or this type of nodule looks more of a benign. So ultrasound is a very important, yes Pavan, very good, thyroids. Ultrasound is very important for differentiating these things. Okay, so when the ultrasound says it is less than 1 centimeter, then in these cases you can follow up. You can tell the patient that at this moment there is nothing to worry about, and ask the patient to come after 3 months or 6 months, and then you can repeat the investigation. But if it is more than 1 centimeter, then you go for FNAC. Fine needle aspiration cytology. This is overall the investigation of choice for solitary thyroid nodule. Okay, this is a very common question. What is the investigation of choice? It is FNAC. Okay, and you use very, very thin needle, 23 gauge to 27 gauge needle for FNAC of the thyroid. Okay, so when you do the FNAC, you have different types of results. Okay, FNAC, after doing the FNAC, you will send it for the cytology to the pathologist, and now they will give different reports. Like they might say that it is inconclusive. Okay, they say it is inconclusive. Or they might say it is benign. Or they can say there is a type of report which says atypia of undetermined significance or follicular lesion of undetermined significance. Or they might say it is a follicular neoplasm. Or they might say it is highly suspicious of cancer. Or they can say it is cancer. Okay, so inconclusive, benign, atypia or follicular lesion of undetermined significance, follicular neoplasm, highly suggestive of cancer, or cancer. These are the different possible results. Based on this, there is a classification that is known as Bethesda classification. So as per the Bethesda classification, this is Bethesda 1, this is 2, this is 3, 4, 5, 6. Okay, so now we should know that what should be done after this. Okay, so if it is highly suggestive of cancer or cancer, then you don't have to think much. Consider it as cancer and go for, in most of the cases, you go for total thyroidectomy. Okay, mostly total thyroidectomy. Few cases where you can go hemi, that we'll see later when we'll talk about cancer. Otherwise, mostly total thyroidectomy. If it is inconclusive, then repeat FNAC. This time take the help of ultrasound so that you should be very sure that the needle is going into the nodule only. So ultrasound guided FNAC you can repeat. If it is benign, mostly you can do follow-up. Okay, mostly follow-up. Surgery may be done if it is patient's choice, or if this nodule is causing any kind of compressive symptoms. Okay, suppose the nodule is compressing the trachea or esophagus, which is causing dysphagia, dyspnea, then also you might have to go for surgery. Atypia of undetermined significance or follicular lesion of undetermined significance. These are the cases where you are not sure that it is cancer. At the same time, you are not very sure that it is not cancer. Okay, so there are different options. Either you repeat FNAC or you go for follow-up. These days there are something new in the form of molecular diagnosis, where they can see multiple genes and they can give you some help that okay, this is cancer or not cancer. Or you can go for a diagnostic hemithyroidectomy. Okay, so these are the options if it is Bethesda 3. Bethesda 4, where it is saying follicular neoplasm. Now again, this question has been asked many times. Very, very important that when you do a FNAC, FNAC will tell you just this much, that this is a follicular tumor. It will not tell you it is a carcinoma or a adenoma. Okay, so this is very important, that FNAC cannot differentiate between follicular adenoma and follicular carcinoma. Okay, so that's why if the report comes out to be a follicular neoplasm or a follicular tumor, the next thing you will do is go for a diagnostic hemithyroidectomy. So now when you will do a hemithyroidectomy, you will have sufficient specimen to send it for the proper histopathology examination, because previously what you have done just a cytology. Now you will send the half of the thyroid for the histopathological examination, and in the histopathological examination the pathologist will check in that whether there is capsular or vascular invasion is present. Okay, so they will check capsular or vascular invasion. So if this capsular or vascular invasion is present, it means it is follicular carcinoma. So most of the time for the carcinoma we go for total thyroidectomy, and in this case till now we have done a hemithyroidectomy only. So if you get a diagnosis of carcinoma, the next thing you will do is go for a completion total thyroidectomy. Okay, half you have already removed, and remove the remaining half also. But if the capsular or vascular invasion is not present, then it is follicular adenoma. Okay, adenoma, which is a benign tumor, and already hemithyroidectomy you have done, so no further treatment is required. No, frozen section is not required, Rohit. In these cases, frozen is not done. It is always better you go for a proper histopathological examination. Okay, frozen section is basically done in those cases. Frozen section is not as good as histopathology. Okay, because in histopathology they make different cuts, they make slides, then they see those things. Frozen section will give you a gross thing, a gross idea about in certain cases about the margin status and a few more things, but it is not a good modality here. Okay, because here you will send a proper histopathological examination. Okay, so you might have to wait for maybe 4 or 5 days when you get the report, and after that you can go ahead and do the completion total thyroidectomy if it comes out to be a cancer. Okay, so this is how you manage a case of solitary thyroid nodule. Very important when to do what thing. Okay, if you have any question, any doubt in this, you can ask me. Okay, another thing we'll see, okay, in the thyroid, these days there are lots of questions on that. Graves' disease. Graves' disease is a type of hyperthyroid or thyrotoxicosis. So this is primary thyrotoxicosis. So the first thing we'll talk about Graves is what is the cause. Okay, it is an autoimmune condition. Autoimmune disease. So if it is autoimmune, means there are certain autoantibodies are present. What autoantibodies? Anti-TSH receptor antibody. Anti-TSH receptor antibody, which is also known as thyroid stimulating immunoglobulin. Thyroid stimulating immunoglobulin or anti-TSH receptor antibody. Mostly you will see 20 to 40 years is the age group. 10 times more common in females as compared to males. Okay, so in Graves' disease, what is the specific test for confirmation? If you want to know one thing, then it is FNAC. Okay, it is FNAC which is done as the investigation of choice. Treatment and prognosis of follicular adenoma is hemithyroidectomy. Okay, prognosis is very good. It is not a cancer, so we don't talk about prognosis in a benign condition. Okay, when we talk about carcinoma, I'll tell you how to treat follicular carcinoma, but this is a benign tumor, and benign tumor, the patients live like as long as a healthy person lives. Okay, so prognosis wise, it is absolutely fine. Okay, so clinically, the patients will have all the features of thyrotoxicosis. All the features of thyrotoxicosis or hyperthyroidism. Not going into all the features, but yes, weight loss, heat intolerance, okay, palpitation, increased appetite, diarrhea. Then a patient can also have this problem like in case of females, amenorrhea. Okay, there are eye signs, lots of eye signs are there. Exophthalmos and lid lag, lid retraction, those things will also be seen. Thyroid stimulating immunoglobulin. Thyroid stimulating immunoglobulin. Okay, Gaurav. Yes, gold standard investigation of choice is FNAC only. But it's not that any patient who comes with the solitary thyroid nodule, the first thing you do is FNAC. Okay, we have seen that how, in what order we have to go for those investigation. Okay, so in this case, in case of Graves' disease, how will you investigate? Okay, recently there was a question on this also. So first you will do the thyroid profile. You will find decreased TSH, T3, T4 may be high, may be normal, but always you will find TSH is low. Another thing is there is a test known as radioactive iodine uptake. Okay, radioactive iodine uptake. Normal uptake in a thyroid scan is around 15 to 30%. This will be very high in Graves. In Graves, the uptake can be like 90%, more than 90%. Okay, radioactive iodine uptake. Most common eye signs, if you ask, it is exophthalmos only. Exophthalmos is the most common. Earliest is, it is known as Stelvach sign, that is staring look. Staring look or Stelvach sign is the earliest eye sign which appears. Okay, then there is anti-TSH receptor antibody in serum. Okay, that is known as TRAB. Okay, TSH receptor antibody, that will be high. You can get the ultrasound. Ultrasound will not help much, but yes, it will just show that there is increased vascularity and increased size of the gland. Not much help. Okay, so these are the investigations you can do in Graves' disease. No role of FNAC. Okay, remember, there is no role of FNAC in Graves' disease until unless you find some suspicious nodule. That is a different thing. Otherwise, FNAC is not done. Okay, this was the question which was asked, that which set of investigations are done, and in 3 options there was FNAC. There was just 1 option where these things were there, and these are the the investigations you will do. Coming to the treatment option, see, there are anti-thyroid drugs, 3 treatment option. Then there is radioactive iodine ablation, and there is surgery. Surgery means total thyroidectomy. Total thyroidectomy. Okay, as most of the patients are young and the patients are mainly female, so the first line treatment in most of the cases is antithyroid drugs. Okay, antithyroid drugs like propyl thiouracil. Yes, it is not needed, Ashwarya. It is not needed. Propyl thiouracil, PTU. Then carbimazole, methimazole. Okay, so any of these antithyroid drugs along with a beta blocker. Beta blocker non-selective, mostly people use propranolol. Okay, so propyl thiouracil is the drug of choice in first trimester of pregnancy. First trimester. After that, you can again switch the patient to carbimazole or methimazole. In first trimester, you will give propyl thiouracil for 12 weeks only. Okay, so this is the first line treatment. The disadvantage is long duration. Okay, the treatment has to be taken for at least like 1.5 years, sometimes 2 years. And also there is risk of recurrence or relapse. Radioactive iodine ablation. Which isotope of iodine you will use? This is for the treatment purpose. Iodine 131. Okay, this you will give again in the tablet form. Usually the dose which you give is 8 to 12 millicurie. 8 to 12 millicurie. So when this goes inside, it will produce gamma rays and beta rays that will destroy the thyroid. Okay, but the disadvantage is it will lead to permanent hypothyroidism. Okay, sooner or later it will cause permanent hypothyroidism. So although a very good treatment option, radioactive iodine ablation, just 1 dose or maximum 2 doses are required, but it is absolutely contraindicated in pregnancy and in lactation, because this is a radiation, and we all know that any kind of radiation is contraindicated in pregnancy and lactation. No, we don't use corticosteroids. Okay, Reddy, we don't use corticosteroids. Relative contraindications is if there are severe eye signs and if there is arrhythmia, and also in case of children. Okay, relative means you can use, but a bit cautiously. Okay, this should not be this should not be the first line treatment in these cases. Severe eye signs, arrhythmias, children. Surgery is mainly indication of surgery is the first thing is if it is patient's choice. Patient himself or herself, they are saying that get it removed. If there is any suspicious nodule in it, although it is very less common, but suppose you find a suspicious nodule in Graves' disease, then also it is indicated. If it is causing compressive symptoms, or in case of pregnant female with failure of medical management. Medical management is not helping out the patient. Radioactive iodine ablation you cannot do, so then you have to go for surgery. Yes, severe eye signs when the patient is having too much of exophthalmos or lid lag or lid retraction, because this radioactive iodine ablation can exaggerate the eye sign. So if it is a little bit of 1 or 2 eye signs, it is okay. But if the patient is having most of the eye signs, it is Graves' ophthalmopathy. You can read about those eye signs in the eye ophthalmology. Okay, so if those are very severe, then it is better not to give this treatment option. For eye signs, you have to give this only anti-thyroid drugs, or you can go and take out the thyroid gland. Okay, either you do surgery or you give anti-thyroid drugs. Okay, so these are the 3 options for the treatment of Graves' disease, surgery being the least preferred option. Surgery being the least preferred option. And suppose you are planning surgery, then you need to prepare for surgery. Okay, you cannot immediately take the patient for surgery because this thyroid gland is producing very high T3, T4. So if you directly take the patient for surgery, then during surgery it can secrete a very high amount of T3, T4 in the circulation, and patient can go into thyroid storm. We'll discuss about thyroid storm. So that's why preparation for surgery means you have to make the gland a bit euthyroid for a brief period so that you can go ahead and do your surgery. Okay, for that you will give anti-thyroid drugs like for at least 4 to 6 weeks. Beta blocker for like 2 weeks before the surgery. And Lugol's iodine for like 10 to 14 days before the surgery. Okay, so when you give these drugs, your thyroid will be relatively less hyper at the time of surgery. This is what you want. Yes, all of these treatment options, first the patient will be euthyroid. In case of anti-thyroid drugs, patient will remain euthyroid most of the time. But in case of ablation and in case of surgery, first the patient will become euthyroid, but ultimately the patient will become hypothyroid. So that's why after these treatment options, we give the patient thyroxine supplementation for rest of the life. Okay, the patient needs thyroxine supplementation for rest of the life. Another important topic we'll see is very important. Every year you will get the question on this: complications of thyroid surgery. Okay, what are the complications of thyroid surgery when you do a thyroidectomy? First we'll see bleeding. Okay, bleeding, if it occurs during the surgery, you can manage it. But if it occurs after the surgery, then there will be a hematoma, and this hematoma can cause the pressure on the trachea and it will lead to airway obstruction. Airway obstruction. So for this airway obstruction, immediately you have 2 options. Either you put an endotracheal tube, if this is in the option, or you will open the wound. Because there is collection just under the wound, so the moment you will open, the hematoma comes out, the obstruction is relieved, and after that you will shift the patient to OT. Shift patient to OT and control the bleeding. Okay, usually the bleeding is not from a very big vessel, but whatever small bleeding is happening, the problem is that bleeding is causing obstruction of the airway, and that is the major problem in these cases. Okay. Second complication, dyspnea, that is a respiratory problem after the surgery. So why it causes dyspnea? See, one of the cause we have already discussed, bleeding. And sometimes while manipulating the gland, larynx is just here, so sometimes laryngeal edema can lead to this, dyspnea. Sometimes there is when there is a very large thyroid swelling, it can cause the weakness of that tracheal wall, and that can cause breathing problem after the thyroid is removed. That is known as tracheomalacia. Nerve injury can cause the problem. Nerve injury we'll discuss. And hypocalcemia can also lead to dyspnea. So now just one question from my side for you people. How does hypocalcemia? Okay, just tell me, suppose a patient underwent a hemithyroidectomy and she develops dyspnea in the post-op period, then among these options, which is having the the least chance of causing the dyspnea? Okay, like here only I'll ask, 35-year-old female after right hemithyroidectomy develops dyspnea in post-op period. What is least likely reason? Option number A, B, C and D. Tell me what is the least likely cause of that dyspnea which develops after a right hemithyroidectomy in a middle-aged young female. Okay, any guess? Was these kind of questions they ask in the exam? Okay, see, hypocalcemia occurs when you remove all the 4 parathyroids by mistake. Okay, you are doing a surgery and you have removed, because parathyroids are very closely related to the thyroid. So many times you might remove parathyroid along with the thyroid, so that will cause hypocalcemia. And remember, when we are doing a right hemithyroidectomy, we remain on the right side, we don't go on the left side. Okay, so if you are doing a hemithyroidectomy, if you do mistake also, then by mistake also you can remove only 2 parathyroids. And even if 1 parathyroid remains with the patient, that will take care of the calcium level. Okay, so the answer here is hypocalcemia. Hypocalcemia will occur, or the chances of hypocalcemia can occur when you do a total thyroidectomy. Okay, so that's why answer is hypocalcemia. Just I gave you this question because these kind of questions these days are common. Yes, most of you are right. Okay, third we will see nerve injury. Okay, external laryngeal nerve injury, although it is most commonly injured as compared to recurrent laryngeal nerve. So when there is external laryngeal nerve injury, it will cause loss of pitch or tone to the voice. Patient will not be able to sing or speak on high notes or high tone. So not a very big problem unless the patient is a professional singer, then it might cause a problem. Recurrent laryngeal nerve, if it is injured on one side, it will cause hoarseness of voice. But if it is injured on both the sides, then both the vocal cords will come in the midline and it will lead to airway obstruction. Okay, so bilateral recurrent laryngeal nerve is very dangerous. Tracheomalacia can be a complication, but this complication most of the time you will see immediately after, when you extubate the patient, you can see tracheomalacia. Okay, and tracheomalacia when you remove the whole thyroid mostly, then you will see tracheomalacia. Okay, next we'll see parathyroid insufficiency. Parathyroid insufficiency. Okay, sorry, there was some technical problem. Okay, so parathyroid insufficiency, see this will lead to, if all the 4 parathyroids are gone, removed by mistake, then it will lead to hypocalcemia. And remember, this hypocalcemia, the symptoms will occur after 3 to 5 days of surgery. Okay, not on the day of surgery, not on the next day or next day of the surgery, because for the initial 2-3 days the calcium reserve which is already in the body, that will take care of the calcium value. So when all the 4 parathyroids are removed, then this problem will occur after 3 to 5 days. So we need to supplement the calcium to the patient in these cases. Last complication, important complication we'll see is thyroid storm or thyrotoxic crisis. Thyrotoxic crisis. This is seen in the patients, like I told you in Graves' disease, first we have to prepare the patient. So if you don't prepare the patient and take patient directly for the surgery, in unprepared thyrotoxic patient, so thyroid gland will release large amount of T3, T4 in the circulation, and due to that the patient will have different symptoms like very high temperature, okay, tachycardia. Initially the BP will increase and then it will cause hypotension, okay, increase respiratory rate, decrease urine output. So all these things will be seen in thyroid storm. So one important thing I want to ask you, that if there is increased temperature, suppose you are doing surgery and suddenly the temperature of patient becomes like 103, 104, then what is the differential diagnosis? What is the differential diagnosis? Okay, one is thyroid storm, and another important, you must have read in the anesthesia, there is something known as malignant hyperthermia. So how will you know it is thyroid storm or malignant hyperthermia? See, one thing is, in malignant hyperthermia there is muscle rigidity, which you will not see in this. There is increase in the creatinine phosphokinase, which you will not see in this. You will see metabolic acidosis, which you will not see in this. There will be hypokalemia in the thyroid storm, that you will not see in this. And thyroid storm occurs mostly in the post-op period, and malignant hyperthermia occurs mostly in the intra-op period. Yes, very good. Malignant hyperthermia. So the treatment of this is dantrolene, and the treatment of thyroid storm, the drug of choice is propyl thiouracil. Propyl thiouracil, beta blocker, okay, sodium iodide, potassium iodide. These drugs you will do, and in severe cases you might have to put the patient on hemodialysis. Okay, so these are the important things about the complications. Okay, next thing we will see is thyroid malignancies. Okay, so papillary thyroid cancer. Papillary thyroid cancer, this is the most common. Okay, generally young females, 20 to 40 years, more common in females as compared to males. And the risk factors, one risk factor is we have seen thyroglossal cyst, if there is radiation exposure in the past, and we'll see this thing if there is Hashimoto's thyroiditis. Okay, what is the important thing you will see in the microscopic examination? Okay, microscopic examination, you will see orphan NEI nuclei. Okay, Samoma bodies. Okay, and it is not encapsulated. Not encapsulated means there is no capsule on this tumor. So see, all these tumors, papillary thyroid, follicular thyroid, medullary thyroid, anaplastic, all these tumors, they spread by local route, lymphatic route, as well as hematogenous route. Okay, in papillary thyroid cancer, the most common route of spread is lymphatic route. Okay, and clinically most of the patients will come as solitary thyroid nodule. Okay, they come with a small nodule. Now see, suppose this is a patient and this is the neck of the patient. So suppose there is a small focus of tumor. So this is occult tumor, means clinically the patient has not yet felt that there is any swelling in the thyroid gland, but this has already spread to the lymph node and the lymph node has enlarged. And now the patient comes with the swelling at the side of the neck. So when you do the FNAC of that lymph node swelling, you will see the features of papillary thyroid cancer. So that thing is known as lateral aberrant thyroid. A very, very important MCQ question. What is lateral aberrant thyroid? It is lymph node metastasis from occult papillary thyroid cancer. Lymph node metastasis from occult papillary thyroid cancer. Yes, very good. See, overall, Damsonian, this is overall the most common cancer. Iodine deficient, insufficient, whatever, it is overall the most common cancer. Okay, we also, when we do surgery, this Delhi is not an iodine deficient area, but still the most common type of tumors we see is papillary thyroid cancer. Okay, sufficient, insufficient, this is the most common overall cancer. Okay, don't get confused. Investigation of choice is FNAC. Tumor marker is serum thyroglobulin. Now the treatment is, see, this is a very good tumor, so in few cases we can go for hemithyroidectomy, but in most of the cases we have to go for total thyroidectomy. So let's see one to go for what? If there is any distant metastasis, if there is lymph node metastasis, if the tumor is going outside the thyroid, extrathyroidal extension, okay, and if there is you can say size more than 4 centimeter, if there is any history of radiation in the past, if there is bilateral nodule, or the FNAC says high grade type of tumor. So if any of these are present, we'll go for total. If all of these are absent, then we can go for hemithyroidectomy. Okay, so this is a tumor where you can go for total as well as hemi because the prognosis is very good. No, see, tumor markers are never used for the investigation. Okay, tumor marker is serum thyroglobulin. Investigation of choice is this. This is serum thyroglobulin. Okay, it does not have too much of importance in the diagnosis. It has importance in the prognosis and in the follow-up. It does not help very much in the diagnosis. Investigation of choice is FNAC. Okay, just do the FNAC. FNAC will tell you it is papillary thyroid cancer. Okay, so tumor marker in none of the tumors in the body are the investigation of choice. They are never investigation of choice. And also, if the lymph nodes are involved, then you have to remove level 6 plus modified radical neck dissection. You will remove level 6 group and level 1 to 5 on that side. But if lymph nodes are not involved, then follow up. You don't have to do anything for neck lymph node in these cases. Okay, this is different in one tumor that we'll see. And this has the best prognosis among thyroid cancer. Best prognosis among thyroid cancer. The survival rate, the 90-year the 5-year survival rate is more than 95% in these cases. Okay, now next tumor we'll see, that is follicular carcinoma. Okay, this is the second most common. Risk factor here is multinodular goiter and iodine deficiency. Multinodular goiter and iodine deficiency are the most common risk factor. The most common route of spread is hematogenous. Hematogenous. It mainly goes to the bone. Which bone? Vertebra. Okay, in vertebra it will cause osteolytic pulsatile bony mets. Osteolytic pulsatile bony metastasis this will give. Okay, and follicular carcinoma, the treatment is mostly same. The first problem is you will have difficulty in diagnosing, because FNAC will tell you follicular neoplasm, so you have to do the same thing. First you do a diagnostic hemithyroidectomy, and when the histopathology says it is cancer, then you have to go for total thyroidectomy. So mostly total thyroidectomy. Very rarely hemithyroidectomy is required. Plus minus level 6 plus minus MRND. Plus minus means if it is involved, you do remove level 6 and modified radical neck dissection. If lymph nodes are not involved, you don't have to remove it. Okay, yes, it is treated like those in solitary thyroid nodule, what I told you. All the tumors they present as just one nodule. All the tumors they present as solitary thyroid nodule only. Okay, Damsonian. Now there is a variant of this which is known as Hurthal cell carcinoma. Okay, this is a variant of follicular thyroid cancer. Slightly more aggressive variant. And in this case, when you will see the cells, there will be Hurthal cells are present. So you will see on histopathological examination, you will see oxyphilic or oncocytic cells. Oxyphilic or oncocytic cells which contains very high mitochondria. Okay, investigation treatment is same as follicular thyroid cancer. Hurthal cell cancer, just remember it is a type of follicular thyroid cancer. which has oxyphilic or oncocytic cells, and it is treated same as follicular thyroid cancer. The next type we'll see is anaplastic thyroid cancer. Anaplastic thyroid cancer is luckily very rare. Just 1 to 2% of the total thyroid malignancies are anaplastic, mostly in elderly patients. Male-female incidence is equal. Okay, this is considered as most malignant endocrine tumor of the body. Most malignant endocrine tumor. Papillary on positive opposite side treatment. What is the meaning of this H? What is the meaning of this papillary on positive opposite side treatment? I really don't understand what you want to ask. Opposite side treatment. I don't know if you can reframe your question in another form. Okay, so most common route of spread here is local. Okay, locally it involves the surrounding structures. It might involve the trachea, esophagus, larynx, recurrent laryngeal nerve. Okay, and mostly advanced, and treatment is mostly palliative. Palliative treatment, chemotherapy, radiotherapy, and sometimes suppose it is putting pressure on the trachea, then you might have to just remove the isthmus. Isthmectomy. Papillary carcinoma lymph node, this is I had written. If lymph nodes are present, level 6 plus MRND. If it is not present, it is follow-up. The same meaning is this. It is the same thing. This and that is, this meaning is same as that meaning. Okay, the same thing. Plus minus means if it is present, remove it. If it is not present, don't remove it. This is what I had written here. Now on the positive lymph node, contralateral side is not treated. Level 6 you will remove. Level 6 is central, but you don't have to go for the other side, the radical neck dissection. You have to just remove just on that side modified radical neck dissection. You don't have to remove the other side lymph nodes. Okay, other side you will remove if the lymph nodes on the other side are involved. Okay, you will do MRND on that side where the tumor is there. Okay, contralateral side is not treated. Not just this, for any cancer, contralateral side is not treated. Okay, palliative treatment is required for anaplastic thyroid cancer. Next we'll see medullary thyroid cancer. Medullary thyroid cancer. See, medullary thyroid cancer is having a different origin as compared to the above tumors which we have seen. Those tumors, they arise from the follicular epithelium. This arises from the parafollicular cells. From parafollicular cells or parafollicular C cells, you can say. 75% of the time it is sporadic, means happening for the first time in a family member, but 25% of the time it can be familial, like it runs in the families, like Men syndrome, Men 1 syndrome, Men 2A and 2B syndrome, where the gene mutation is Rett gene. Okay, we'll discuss Men syndrome separately. Okay, in this case, the tumor marker is different. Tumor marker is calcitonin and carcinoembryonic antigen. So here the tumor marker is calcitonin and CEA. FNAC will show you a special feature, amyloid stroma. Amyloid stroma on FNAC. And here the treatment also is different. In all the cases, no matter what is the size, what is the age, what is what, in all the cases you have to go for total thyroidectomy. And level 6 you have to remove in all the cases, plus minus MRND. Okay, so total thyroidectomy in level 6, so you have to remove in all the cases. Modified radical neck dissection you will do if the lymph nodes are positive. If it is not positive, no need to do MRND. But level 6 you have to remove in all the cases. All the cases. Okay. So these are the main tumors of the thyroid. Okay, there is a lymphoma also. Just remember one thing about the lymphoma, that is very rare, and it is a non-Hodgkin's lymphoma, which is B cell type. To be more specific, it is diffuse large B cell lymphoma. Diffuse large B cell lymphoma. Treatment is mainly chemotherapy. Okay, so these are the different thyroid malignancies. Okay, so see these tumors: papillary thyroid cancer, follicular thyroid cancer, and Hurther cell cancer. These tumors are good tumors of the thyroid. Good means in the term of prognosis, and they are known as differentiated thyroid cancers. Differentiated thyroid cancer. So in these cases, once you have done the surgery, how will you do the, you can say, follow-up. Follow-up means after surgery, what will you do? Post, or we should write post-surgical evaluation. Post-surgical evaluation. So I'll just tell you what are the things we do in post-surgical evaluation. The first thing is keep the TSH towards the lower side. Initially TSH suppression. Get the serum thyroglobulin level done. So now you will know the role of serum thyroglobulin. See, the tumor markers, what they do is they act as a prognostic factor and they help in the follow-up. Suppose you, before the surgery, you have done the tumor marker, it is high. After the surgery, maybe after 6 weeks, you repeat the thyroglobulin again. So if you have removed the disease completely from the patient's body, this level of thyroglobulin should come back to normal. If it is not normal, if it is still high, it means that tumor is left somewhere in the body, either in the form of primary or in the form of secondary. Okay, so that's where the serum thyroglobulin level will help. So if it is there, if the tumor is there, then you will see you will go for radioiodine scan. Radioiodine scan. And you can go for RAI ablation for any residual or recurrent tumor. Okay, for any residual or recurrent tumor, you can go for ablation. So when you are doing ablation for a residual or recurrent tumor, the dose of iodine 131 is high. It is 30 to 100 millicurie. Sometimes you can go up to 300 millicurie also. Okay, so this you do in the post-surgical evaluation of differentiated thyroid cancer, that is papillary, follicular or Hurther. One last point we'll write. No PET CT, absolutely no role. Okay, Damsonian, no role of PET CT. Okay, it is not at all required. That in medullary thyroid cancer, there is no role of radioiodine scan or RAI ablation. Okay, because it arises from the parafollicular cells, and parafollicular cells have nothing to do with the iodine. Okay, so this we finish the thyroid tumors. One more thing we'll see, that is thyroiditis. 3 types. Okay, we'll write like this: Hashimoto's, Dekervain's, and Riedl's. Okay. Hashimoto is the most common type and it is autoimmune. Autoimmune means there will be some autoantibody. Anti-thyroid peroxidase, anti-thyroglobulin, anti-TSH receptor. Okay, so these are the 3 main autoantibodies. This is the most important. Anti-TPO you will see in more than 90% of the Hashimoto thyroiditis patient. So in this case, what is the status of the thyroid? Initially patient becomes hyperthyroid. Then the patient will become euthyroid. MTC is medullary thyroid cancer, SOZIL, medullary thyroid cancer. And then ultimately the patient will become hypothyroid. Okay, in case of Hashimoto's. FNAC will show chronic, you can say lymphocytic infiltration. Lymphocytic infiltration. Treatment surgery is not required in most of the cases. Thyroxine supplementation. Surgery may be required if you find some suspicious feature of malignancy or if it is causing compressive symptom. Remember, in thyroid disorder, if any swelling, no matter what is the diagnosis, if that swelling is causing compressive symptoms, then there is only and only one treatment, that is surgery. Okay. Dekervain's is having the viral etiology. Okay, viral infections of the upper respiratory tract. Okay, influenza virus, adenovirus, Epstein-Barr virus, mumps virus. They are the cause, infective etiology. Okay, here one thing is different from the other, that it will cause painful and tender thyroid swelling. Painful and tender thyroid swelling. There will be fever, will be increased ESR. Here the patient will be initially hyper, then euthyroid, then hypo, but ultimately the patient will come back to the euthyroid status. Okay, patient will pass through all the things, hyperthyroid also, euthyroid also, hypo also, but ultimately patient will come back to euthyroid status. FNAC will show non-caseating granuloma. And treatment, like any other viral infection of the upper respiratory tract, it is spontaneously resolve. Okay, it will resolve on its own. The only thing you have to do is, till it gets spontaneously better, it might take 1.5 months. Symptomatic treatment in the form of maybe some painkiller, some steroids, just for a brief period. Okay, symptomatic treatment. The disease will get better on its own in a month or 1.5 months. Third type is Riedl's. Riedl is of unknown etiology. There is basically fibrosis in the gland. Fibrosis in the gland, and hence the patient will be hypothyroid from the beginning. Okay, there will be no hyper state in Riedl's, hypothyroid. And FNAC, either it is not possible because of very hard swelling, or it will just show the fibrous tissue. Treatment is mainly thyroxine supplementation. Okay, steroids have role here. Steroids, thyroxine. Sometimes we give mycophenolate, mofetil. Okay, so these are the treatment options for renal thyroiditis. Okay, so these are the three main thyroiditis. In books also mostly these three thyroiditis are written. But there is one more thyroiditis from which recently they are asking question. Okay, so that I'll write here. Very, very rare acute suppurative thyroiditis. Acute suppurative thyroiditis. Okay, extremely rare, mostly seen in children. This one, decurvence is painful, Aishwarya. Decurvence. Okay, rest two are not painful. Children, mainly bacterial infection. Okay, streptococcus, staph aureus, anaerobes. This can also give a painful tender swelling. Painful tender. FNAC in renal is usually not possible because very hard thyroid swelling. And even if you do FNAC, it will just show the fibrosis. No role of, absolutely no role of immunosuppression in Hashimoto's. Okay, no role of immunosuppression in Hashimoto's. We treat Hashimoto's day in and day out. Nothing. Okay, you come to this, I don't know in other parts of the India, but if you come to Delhi and the surrounding part, you can say mostly 20% of the females, they have Hashimoto's. All are living nicely and happily with their family. Few patients then need thyroxine supplementation. Okay, so no role of immunosuppression. The question they ask is how does this bacteria reaches the thyroid? So in the embryological period, there is a communication between oropharynx and the thyroid. This communication is pyriform sinus. So if there is persistent pyriform sinus, so now the bacteria can travel from the oropharynx to the thyroid and cause this problem. And this persistent pyriform sinus is fourth branchial arc anomaly. So this kind of question they ask. Fourth branchial arc anomaly causes which type of thyroiditis? Answer is acute suppurative thyroiditis. Treatment is mainly IV antibiotics. IV antibiotics. Okay, so these are the important things about thyroid. The next chapter we go, that is parathyroid. Okay, parathyroid. Okay, so in parathyroid, remember one thing. Suppose this is a posterior aspect. So there are two superior and two inferior parathyroids. Superior arises from the third pharyngeal pouch and inferior from fourth pharyngeal pouch. Okay, so it is ulta. Okay, the superior from third and inferior from fourth. And inferior, it has variable location. Okay, it can be seen at the lower pole of thyroid. It can be treatment for riddles. I told you mostly we give steroids, and the immunosuppression there we are giving in the form of not immunosuppression as well, and anti-proliferative mycophenolate, mofetil, thyroxine supplementation. Okay, Nishant, I had written there. Okay, this is the treatment of riddles. Okay, so inferior can be variable. So the main role of parathyroid is it is producing parathyroid hormone. Parathyroid hormone maintains the calcium level. Okay, it maintains the calcium level. How does it maintain the calcium level? It takes the calcium from bone. It causes increased absorption of calcium from kidney. Also, it causes increased absorption from GIT, but remember, on GIT it does not act directly, it will act via vitamin D. Okay, and any increase in the PTH, if there is increased value of the parathyroid hormone, then it is known as hyperparathyroidism. Hyperparathyroidism, HPT. So this hyperparathyroidism can be primary. Primary is when it is causing increased PTH production because of some problem in the parathyroid gland itself, like a parathyroid adenoma. We'll discuss this, or a parathyroid hyperplasia, or a parathyroid carcinoma. Okay, that is primary hyperparathyroidism. Secondary hyperparathyroidism is because of hypocalcemia in the body. Okay, like just take one example, chronic renal failure. Chronic renal failure causes hypocalcemia, and in response to that there is increased PTH. Okay, or maybe vitamin D deficiency, malabsorption syndrome. So that causes secondary hyperparathyroidism. Tertiary hyperparathyroidism occurs, suppose the patient is having secondary hyperparathyroidism like chronic renal failure, and if you don't treat the secondary hyperparathyroidism early, then patient will go, or the gland will go into autonomous function. It will keep on producing excessive PTH. That is tertiary. Okay, when the gland becomes autonomous, so irrespective of the calcium level in the body, it will keep on producing excessive PTH. So this tertiary occurs because of prolonged secondary hyperparathyroidism. So if there is secondary hyperparathyroidism, we should treat it, I mean the main pathology, we should treat it as early as possible. Otherwise the gland will become autonomous, then it will not see what is a normal calcium value, it will keep on producing excessive PTH. Okay, clinically these days of the hyperparathyroidism, patient will have, bony pain, polyuria, polydipsia, fatigue, renal stone. So these are the common symptoms with which the patient will present. Investigation will see increase in the serum PTH value and increase in the serum calcium value. Serum PTH is normal is 15 to 65 picogram per liter. So it will be more than 65, it can be like 300, 400, 500. It is picogram per ml actually. Okay, increase in serum PTH, serum calcium is normally 9 to 11 milligram per deciliter. Okay, so now when we talk about parathyroid adenoma means out of 4 glands, one of the gland is enlarged and it is producing excessive PTH. Okay, so parathyroid adenoma is responsible for more than 80% of primary hyperparathyroidism. And the gland which has enlarged and producing excessive PTH, that is mostly inferior parathyroid. Inferior, either on the right side or the left side, but it is mainly the inferior parathyroid which is enlarged and producing excessive PTH. Parathyroid hyperplasia, which is responsible for 10 to 15% of primary hyperparathyroidism, is a condition where all the four parathyroids are enlarged and producing excessive PTH. And parathyroid carcinoma is very rare, just 1%. Is a condition where one of the gland will go into malignant transformation. One of the gland becomes malignant. Okay, so these are the three types of primary hyperparathyroidism. Now see, the problem is the main cause of primary hyperparathyroidism is adenoma. Okay, so the parathyroid glands are very small. Even if it becomes big, it is still small. Okay, a very small thing, if it is enlarged, it becomes small. So it is very difficult to localize that among the four parathyroid, which one is the culprit and which one is causing the adenoma and the symptom to the patient. So localization is an important problem, and the investigation of choice for localization is a nuclear scan, very important. Every year they ask question on this is technetium-99 sesta-MeB scan. Technetium-99 sesta-MeB scan is the investigation of choice to see that out of four parathyroid which is causing problem. The treatment is of parathyroid adenoma. You have to remove that gland. Okay, removal of adenoma. These days we give with a small incision. So now the problem is when you remove the adenoma after giving the small incision, very small gland, so how will you confirm that you have removed the correct thing? Okay, confirmation, because you might remove something else and think that this is adenoma. So how you should be very sure that the swelling which you have removed is parathyroid adenoma only. So one option of confirmation is you can go for frozen section. Another option is before removing the swelling, just get the serum PTH level done, and 10 minutes after the surgery check the serum PTH again, and if there is drop in serum PTH more than 50% of the pre-op values, then that is also a hint that you have removed the correct thing. Okay, so this is known as Miami criteria. In you can say in 10 minutes after the surgery, drop in serum PTH more than 50%. Okay, so this is the treatment if it is adenoma. What will you do if it is a hyperplasia? Because in hyperplasia all the four glands are enlarged and we need parathyroid or PTH for the calcium levels. So there are two options. Either you remove 3.5 glands, or you remove all four, and after removal of all the four, take half of one gland and put it back in the patient's body in the forearm muscle. Okay, auto transplant in the forearm muscle, basically the brachioradialis muscle. Okay, so mainly people they prefer this option because suppose you put those pieces, small pieces of the parathyroid in the forearm muscle, So those pieces will take the blood supply from the muscle and they will produce PTH. And in future, if that causes excessive PTH, it is easy to go and take out some pieces from this area as compared to leaving half of the gland back in the neck. And in future, if that half gland is causing problem, it is very difficult to go back in the neck and do the surgery and take out a part of that, because after the initial surgery there will be fibrosis and adhesions in the neck. The second surgery will be very difficult. Okay, so that is a problem we will face in these cases. Okay, one more thing you remember in this is that when we talk about the treatment, what is the indication for surgery? Not in all the cases you go for surgery. Indication for surgery is if the age of the patient is less than 50 years. Treatment, I will repeat again, okay, derma dream, age less than 50 years, derma dream. Okay, now the people, they are not too much, I mean, as you can see the result, derma was very favorite for the past 5-7 years, but now people are again they are moving towards the core branches like medicine, surgery, gynae. Age less than 50 years, serum calcium more than 12 milligram per deciliter. If there is decrease in the bone mineral density, okay, when there is less than minus 2.5 standard deviation on DEXA scan. Okay, this scan is you check for the bone density, and decrease renal function, that is GFR less than 60 ml per minute. Now these are the indications for surgery in parathyroid adenoma. Not all the cases you go for surgery. These are the indications for surgery in parathyroid adenoma. Yes, very good, derma dream. That should be the spirit. Okay, doesn't matter. Indication for surgery in parathyroid adenoma. These are the indications. Okay, so for adenoma, you go for removal of that involved gland. For hyperplasia, you go for either 3.5 glands or removal of all the 4 with auto-transplantation of half of one gland. For carcinoma, which is although very rare, you have to remove that parathyroid as well as hemithyroidectomy. Okay, removal of parathyroid carcinoma with ipsilateral hemithyroidectomy, plus minus if the lymph nodes are there, you might have to go for modified radical neck dissection. So this is the treatment for carcinoma. Okay, so this is the treatment of adenoma, hyperplasia, carcinoma. What is the investigation of choice? After removal of the adenoma, how will you confirm it is adenoma? What is primary, secondary, tertiary hyperparathyroidism? What is the indications for surgery in parathyroid adenoma? Just one more thing. Indication for surgery in, okay, you should write like this. Treatment of Hejira is derma dream. Okay, fine. Treatment of secondary hyperparathyroidism. Secondary hyperparathyroidism, GFR less than 60 ml per minute. Mostly calcium supplementation. Indication for surgery. Indication for surgery is if the serum PTH is more than 800. If the any gland is more than 1 centimeter. If the serum calcium multiplied by serum phosphorus is more than 70. If there is a calciphylaxis. Calciphylaxis is deposition of calcium in the subcutaneous tissue. If there is severe pruritus and if there is intractable anemia. So these indications are mainly in the chronic renal failure when the patient is having secondary hyperparathyroidism, when to go for surgery of that. Otherwise you give calcium supplementation. Okay, Hanji, I thought it is Hejira is the name. Sorry, you are still derma dream for us. Okay. Treatment for tertiary hyperparathyroidism, always surgery. Okay. Here when we are talking about the surgery, this surgery is the same thing, either 3.5 gland or all 4 with auto transplantation of half of 1 gland. Okay, so surgery means this surgery, either 3.5 gland or all the 4 glands with auto transplantation of half of 1 gland. Okay, fine. So this is about parathyroid. You will not get anything outside this in the parathyroid. Next, in the adrenal gland. Adrenal gland, you need to know just 2 things. First, we will talk about is pheochromocytoma. Pheochromocytoma, this is a tumor arising from adrenal medulla. From adrenal medulla or chromaffin cells elsewhere in the body. Elsewhere in the body. Pheochromocytoma, mostly a benign tumor. You can say pheochromocytoma as 10% tumor. So what are the 10% things in pheochromocytoma? 10% of the time it is malignant. 10% of the time bilateral. 10% of the time multiple. Fourth point for, see, first of all, it is not these indications of for surgery for adenoma or hyperplasia. For both. Okay, indications for surgery in adenoma or hyperplasia. Not all cases of adenoma or hyperplasia. It is not hypo, okay, hyperplasia. Age less than 50, serum calcium more than 12, decreased bone mineral density and decreased renal function. Okay, derma dream. These are indications for surgery. Okay, so malignant, bilateral, multiple, 10% of the time in the children and 10% of the time extra adrenal. Now the most common extra adrenal site is around the aortic bifurcation in the abdomen. There are these chromaffin cells are present, which are known as organ of Zuckerkandl. Organ of Zuckerkandl. So that is the most common extra adrenal site of pheochromocytoma. 25% of the time it is familial. Familial means it is running in the families, or you can say it is associated with some syndromes. What are the syndromes associated? Like MEN2A and MEN2B syndrome. von Hippel-Lindau syndrome, neurofibromatosis 1, which is also known as von Recklinghausen syndrome, and familial paraganglioma syndrome. So these are the common syndromes associated with pheochromocytoma. Now see, normal adrenal gland, what it does, it produces adrenaline more than noradrenaline. Pheochromocytoma produces noradrenaline more than adrenaline. If the pheochromocytoma is rising outside the adrenal, means extra-adrenal pheochromocytoma produces only noradrenaline. If the pheochromocytoma is associated with men, pheo associated with multiple endocrine neoplasia syndrome, it produces only adrenaline. And if it is a malignant pheochromocytoma, it produces only dopamine. It produces only dopamine. VHL is, Yusuf, it is von Hippel-Lindau syndrome. Von Hippel-Lindau syndrome. Von Hippel-Lindau syndrome. Okay, clinically, the patient will have, most common clinical feature is hypertension. Okay, that will be seen in 90% of the patient. Palpitation, weight loss, okay, sweating, flushing of face. These are the clinical features, common clinical features. Now, see, if you are suspecting a pheochromocytoma, okay, then how will you know that it is pheochromocytoma? Okay, how will you confirm? So in investigation, first you will do a biochemical investigation to say it is pheochromocytoma. Okay, so for pheochromocytoma, you will check, because it is producing more of these catecholamines, adrenaline, noradrenaline. So you will see the metanephrine and VMA level. VMA is vinyl mandelic acid. Vinyl mandelic acid. So metanephrine and VMA are the byproducts of these catecholamines in the body. So now comes the question whether these values you will check in the serum, or you can say plasma, or you will check in the urine. Where will you check? Okay, this is important question. So serum or plasma, metanephrine, VMA, you will check in high risk patients, and urine you will prefer in low risk patient. So now what is high risk and what is low risk? High risk means if the patient has any syndrome, like those syndromes which we have checked, okay, VHL, men syndrome, familial paraganglioma syndrome, neurofibromatosis, or if there is a family history of pheochromocytoma, or suppose the patient himself or herself had pheochromocytoma in the past, personal history of pheochromocytoma. Those are high risk features, and if these things are not there, then those are low risk patient. There you check urinary, metanephrine or VMA. Okay, so this is important, when to check plasma, when to check urine. So if these values are high, we know that the patient is having pheochromocytoma. But now you need to know that, okay, this pheochromocytoma is present in the adrenal or outside the adrenal, and if in the adrenal, then on the right side or the left side. Okay, so for that you need radiological investigation for localization. Okay, so radiologically, first you go for CT scan. Okay, contrast enhanced CT. If it is not localized, then you go for MRI. If it is not localized on MRI also, then you go for a nuclear scan, which is known as MIBG scan. Okay, meta-ido benzyl guanidine scan. Okay, CT or MRI or MIBG scan. Overall, MRI is the investigation of choice. MRI is the investigation of choice. Okay, so after localization, when it comes for the treatment part, remember pheochromocytoma is a tumor which is producing excessive catecholamines. So again, if you don't prepare the patient and straight away take the patient for surgery, there are chances of complications during surgery. So that's why in this case also you will do pre-op preparation. Pre-op preparation, you will give alpha blocker. Alpha blocker, mainly you will give phenoxybenzamine. This you will give 2 to 3 weeks before surgery. 2 to 3 weeks before surgery. Then after the alpha blocker, you will give beta blocker, and then you will go for surgery. And these days, the most common type of surgery done for the adrenal is laparoscopic adrenalectomy. Laparoscopic adrenalectomy is the most common type of surgery we do for the patient. Okay, so these are the important things about pheochromocytoma. You will not get anything outside this. One more thing we'll see. See, sometimes suppose you are doing radiological investigation like CT or MRI for some other pathology in the abdomen, like suppose for appendix or some inflammatory bowel disease or some other disease, and in that CT or MRI you also find or the radiologist also find out that there is a lesion on the adrenal. There is some mass on the adrenal, but the patient has absolutely no symptoms of any adrenal disease. So that type of lesion or the tumor which is find on which the radiologist find on the adrenal incidentally on an investigation done for something else, that is known as incidentaloma. Incidentaloma. Beta blockers are given when the alpha blockade is complete. After the completion of alpha blockade, you give beta blocker. If you give beta blocker before completion of the alpha blockade, then it can lead to hypertensive crisis. Okay, then it will lead to unopposed alpha action, and that will lead to a hypertensive crisis. Detail of this, if you want to know, in your pharmacology there is something known as Dale's vasomotor phenomena. Read about that, you will know the basic physiology of this. 10% chart, Ashutosh, is this. Previously in this 10%, familial part was also there. Okay, but now the recent data or the study suggests it is 25% of the time familial, not 10%. Okay, so 10%, there is one or two more 10%, like 10% of the time not associated with hypertension, and 10% of the time calcification may also be seen. But the main 10% are these 5. Okay, you can write if you want to know, 10% not associated with hypertension, and 10% of the time there can be calcification in the pheochromocytoma. Mostly when you start alpha blocker, in a week alpha blockade is complete, then you give beta blocker for 1 more week, and then you can operate the patient. Okay, so incidentally discovered. On radiological investigation for some other pathology. Okay, incidentally discovered adrenal mass. So differential diagnosis, you cannot just say the patient that okay, if we don't have any symptom, then we will not do anything for this. It might be some serious thing which has been diagnosed because of your radiological investigation, although most of the time it is a non-functional adenoma. That is the most common differential diagnosis. But it could be functional adenoma also, like the one which producing excessive mineralocorticoid known as Cons adenoma. Cons adenoma or Cushing's adenoma if it producing excessive cortisol. Feminizing or virilizing adenoma if it is producing excessive sex steroids. It could be a pheochromocytoma, it could be adrenocortical carcinoma, it could be a cyst, it could be a metastasis. So it could be anything which has discovered incidentally. So if it is any of these things, you get all the investigation done to find out what is this tumor. Okay, all the investigation possible, biochemical, radiological, to find out what is it. And if any of these are present, then you go for surgery. But the question they ask is, what will you do if it is a non-functional adenoma? I mean, there is a tumor, there is a benign tumor, but it is not producing anything excessively. It is not producing aldosterone, it is not producing cortisol, it is not producing sex steroids, it is not producing catecholamines, but there is a tumor. So that is non-functional adenoma. So what to be done for this? Whether to go for surgery or not to go for surgery. Indication for surgery in non-functional adenoma. All these are functional. So in functional cases, you have to go for surgery. The problem is if it is non-functional, then when to go for surgery. Indication for surgery. So if the size is more than 6 centimeters, okay, or size 4 to 6 centimeter with suspicious features on the imaging, like irregular borders or heterogeneous. If the size is less than 4 centimeter, mainly you follow up size less than 4 centimeter, but if there is with more than 20% increase in size in a year. Okay, so basically meaning I'll tell you, if the size is more than 6 centimeters, straight away go and operate. If the size is 4 to 6 centimeter, you don't have to operate unless there is some suspicious features like irregular border or there is heterogeneity in that mass. If there is size less than 4 centimeter, you don't have to operate unless there is in 1 year it is increasing by more than 20%. Okay, so these are indications for surgery in case of incidentaloma. Okay, this is what you want to see. Okay, dermadream and sosil, non-functional adenoma, and below that is the functional tumor. So in all the functional tumor, you'll go for surgery. In non-functional adenoma, when to go for surgery, these are the indications. Okay, Cons adenoma, Cushing's adenoma, virilizing or feminizing adenoma, pheochromocytoma, adrenocortical carcinoma, adrenal cyst, and metastasis from some other tumor. These are the differential diagnosis. Adrenocortical carcinoma, Aishwarya. It is adrenocortical carcinoma. Okay, men syndrome, if we discuss, there are MEN1, MEN2. So in MEN2 there is MEN2A and MEN2B. These days there is one new syndrome, MEN4. MEN4. Okay, MEN1 is autosomal dominant due to a mutation of MEN1 gene which is located on chromosome 11, also known as Wermer syndrome. Wermer syndrome. Okay, so what are the tumors? All the three tumors starting with P: parathyroid adenoma or hyperplasia, then pancreatic neuroendocrine tumor, and pituitary adenoma. Okay, this is most common. 90% of the patient will have this. Around you can say 40% of the patient will have that, and around 30% of the patient will have pituitary adenoma. So most common tumor you will see in MEN1 syndrome is parathyroid adenoma or hyperplasia. Most common pituitary adenoma you will see in MEN1 syndrome is prolactinoma. And most common pancreatic neuroendocrine tumor is non-functional. Most common functional pancreatic neuroendocrine tumor is gastrinoma, which is associated with MEN syndrome. Okay, so these are the things you should remember about MEN1 syndrome. MEN2 is also autosomal dominant condition due to mutation of red gene. Red gene is present on chromosome 10. Okay, so it has MEN2A and MEN2B. MEN2A is known as Sippel syndrome. In MEN2A there is this parathyroid adenoma or hyperplasia, pheochromocytoma, and medullary thyroid cancer. In MEN2B, which is known as mucosal neuroma syndrome, pheochromocytoma, okay, I'll write here, pheochromocytoma, medullary thyroid cancer, and many small neuromas which are present on the mucosa of the oral cavity or the GIT. Okay, mucosal or GI neuromas. Okay, so in case of MEN2A and 2B, pheochromocytoma you will see in pheochromocytoma you will see in 40 to 50% of cases. Medullary thyroid cancer 100%. Okay, in parathyroid adenoma 10%. Mucosal GI neuroma 95%. So in all the cases of MEN syndrome, sooner or later the patient will develop medullary thyroid cancer. And medullary thyroid cancer is very, very dangerous in these cases. So that's why in this syndrome, MEN2 and 2B, suppose a newborn comes in the family. Newborn in the family, the first thing you will do is get a gene testing done to see whether there is mutation of the red gene or not present or not. So gene testing is present. Gene testing is positive. Positive means the mutation in the gene is present. Means this child or this newborn in sometime in his or her life, he or she is going to have medullary thyroid cancer or these tumors which are there. So that's why in these cases you will not wait for the tumor to develop. You will go for a prophylactic thyroidectomy. You will not let the tumor develop. Before developing the tumor, you will remove it. If it is meant to A, this surgery should be done at 5 years of age. And if it is meant to B, the surgery will be done at 6 to 9 months of age. Okay, so these are questions. When to do prophylactic thyroidectomy if the gene testing is positive in MEN2 syndrome patient, either MEN2A or MEN2B. Okay, and remember these days MEN2B is also known as MEN3. So MEN2B and MEN3 is the same thing. Same thing. So recently a new type of MEN syndrome has come, MEN4, that is also autosomal dominant. It looks like MEN1 but with a different gene mutation, CDKN1B gene, which is situated on chromosome 12. Okay, very few cases have been reported in the literature. So there are mainly in these cases parathyroid and pancreatic tumors. Parathyroid tumors and pancreatic neuroendocrine tumors only. These are present. Apart from this, there can be gonadal, renal, okay, parathyroid and, sorry, not pancreatic, pituitary tumors. Pituitary. Gonadal, renal, pancreatic. Main difference between the 2A and 2B is the tumors. Okay, in 2A there will be parathyroid adenoma or hyperplasia. In 2B there will be mucosal and GI neuromas. Pheochromocytoma and medullary thyroid will be seen in both. Actually in MEN2, 95% of the MEN2 is MEN2A. Just 5% is MEN2B. Okay, just 5% is MEN2B. Mostly it is MEN2A. Okay, Nishant. Okay, so in MEN4, very few cases have been reported in literature, so there is no such guidelines are present. Okay, so if you remember this much about MEN syndrome, that is more than enough. Okay, so now we'll see the important things in the oral cavity cancer and salivary gland tumors, and then we'll go to then we'll take a short break and then we'll do the urology part. Chromosome in MEN4 is CDKN1B. Okay, Manish, CDKN1B gene on chromosome 12. Okay, so oral cavity cancer. Oral cavity cancer is mostly squamous cell cancer. The most common site overall in the world is tongue. Most common site in India is alveobuccal complex. Alveobuccal complex. Prophylactic thyroidectomy, Yusuf, if the patient or the child belongs to MEN1, MEN2A family, then it is done when the child is at 5 years of age, when the child attains 5 years of age. In MEN2B at 6 to 9 months of age, or you can say within first year of life. Within first year you will go and remove the thyroid, because if you don't remove, there are chances, not chances, there are 100% chance that this kid will definitely develop thyroid cancer, medullary thyroid cancer, sometime in his or her life. Okay, so that's why you will remove it, because the chances are 100%. We are not removing in all the cases parathyroid, we are not removing in all the cases adrenal, because there is 40 to 50% or 10% chance that they will develop this. But in medullary thyroid cancer, there is 100% chance that they will develop, so that's why we are doing a prophylactic surgery. Okay, the most common cause is tobacco. In whatever form, smoking, chewing, pan, gutkha, masala, khani, whatever, tobacco. Okay, so in oral cavity cancer, there are certain potentially malignant disorders. Potentially malignant disorders means these are at this moment not cancer, but there are very high chances that they will turn into a cancer. Okay, so you need to remember what are the high risk potentially malignant disorders, medium risk potentially malignant disorder, and low risk potentially malignant disorders. High risk में there is leukoplakia, erythroplakia, and chronic hyperplastic candidiasis. Chronic hyperplastic candidiasis. These are high risk potentially malignant disorders. In medium risk potentially malignant disorders, oral submucous fibrosis. Oral submucous fibrosis is mainly because of that betel nut, erica nut or supari. Okay, it is not because of tobacco, it is mainly because of betel nut or erica nut. Syphilitic glossitis and sideropenic dysphagia. Sideropenic dysphagia is same as Plummer-Vinson syndrome. I hope you remember Plummer-Vinson syndrome, iron deficiency, spoon-shaped nail, that is koilonychia, cheilitis, glossitis, and esophageal web, that is Plummer-Vinson syndrome. Another name is sideropenic dysphagia. Low risk potentially malignant disorders are just some names, you don't need any kind of detail of this. Oral lichen planus, dyskeratosis congenita, and discoid lupus erythematosus. Okay, so these are potentially malignant disorder. Now, if you get a question which has the maximum risk, then there is a type of leukoplakia, speckled or verrucous leukoplakia, that has the maximum risk, followed by erythroplakia. Not all the leukoplakias are dangerous, but this speckled or verrucous type of leukoplakia, that has approximately 50% chances of turning into cancer. Erythroplakia has approximately 40% chances of turning into cancer. Okay, yes, Rohit, you are correct. Erythroplakia, if erythroplakia and a simple leukoplakia is in the option, then you go for erythroplakia. But if there is speckled or verrucous type of leukoplakia, then that has the maximum risk. Okay, that is a recent, you can say, the data which suggests this has the maximum risk. Okay, now in general, when we talk about the oral cavity cancer, in general, the treatment is of basically we need to see the lip cancer, tongue cancer, and the buccal mucosa cancer. Okay, the staging is same for all, and the treatment is also stage wise is same for all. So we need to know the staging and the basic treatment of oral cavity cancers, and then little bit about I'll tell you about the reconstruction in the oral cavity cancer. Okay, staging part. So first I'll tell you the TNM of the seventh stage. Now this time there is 8th edition AJCC. Just see how to remember this. First I am telling you about the 7th edition, and then I'll make the change. I'll tell you what are the changes done in the recent 8th edition. T1 is tumor less than equal to 2 centimeter. T2 is more than 2 to 4 centimeter. T3 is more than 4 centimeter. T4A is involvement of skin, mandible, maxilla. T4B is involvement of carotid vessels, skull base. Okay, so this is T staging. Now in the new edition, what they have said is that they said that it is not just the size of the tumor, but the depth of invasion is also important. Means how deep it is going from the mucosa of that organ deeply. Okay, how deep it is going. So now see, T1 is less than 2 centimeter with depth of invasion less than 5 mm. T2 is 2 to 4 with depth of invasion less than 10 mm. T3 is more than 4 with depth of invasion less than 10 mm. Okay, so up to this you can remember less than 2, 2 to 4, more than 4, depth of invasion less than 5, less than 10, less than 10. Now you see how I have remembered this. Up to this anybody can remember. Now there will be one more thing will come in T2. What will come? Just bring this part down, increasing the depth. Okay, so less than 2 centimeter with depth of invasion more than 5 to 10 mm. That will also be T2. T3 is this, and one more is bring this thing down by increasing the depth. More than 2 to 4 centimeter with depth of invasion more than 10 mm. T4A is this. One more thing comes in T4, this with increasing the depth. More than 4 centimeter with depth of invasion more than 10 mm. T4B is T4B, no change. Okay, so this is the T staging in the oral cavity cancer. Now if you see like this, it appears very complicated. Actually it is complicated, but I told you how to make it easy, how to remember it. First you write less than 2, 2 to 4, more than 4. T4A is skin, mandible, maxilla. B is carotid vessel, skull base. Now as per the latest thing, when the depth of invasion is included, first you write depth of invasion less than 5, less than 10, less than 10, and now what I told you. Okay, in T1 it's that. In T2, one more thing, this will also come under T2 only. Okay, this will come under T3 only. This will come under T4 only. T4A I mean. Okay, nodal staging. N1 is single ipsilateral lymph node which is 3 or less than 3 centimeter. Ipsilateral means if the tumor is on the right side of the cheek, then the right side of the neck lymph node is involved. N2A is single ipsilateral lymph node which is more than 3 up to 6 centimeter. N2B is multiple ipsilateral, but none should be more than 6 centimeter. Multiple lymph nodes,
but not more than 6 centimeter. N2C is bilateral or contralateral lymph node. None should be more than 6 centimeter. And N3 is any lymph node more than 6 centimeter. Okay, so this what I have written, the end staging, this is as per the 7th edition. In the 8th edition AJCC, what they did was they said that all these are, they said it as N3A. They said all these are ENE negative. ENE means extranodal extent. The tumor is limited to the lymph node, it has not gone outside the lymph node. And one new category they have added, that is N3B, that is extranodal extent is involved or it is positive. Means the tumor has gone outside the lymph node. Like suppose this is the tumor, this is a lymph node. So in this case the tumor is limited to the lymph node, the capsule of the lymph node is intact. In this case the tumor has breached the capsule and has gone outside. So that is the meaning of ENE negative and positive. M1 is distant metastasis, M0 is no distant metastasis. Okay, so this is TNM staging of oral cavity cancer. This is also a very important staging, although the most important staging is carcinoma breast, but this is also, you can say this is the second most important TNM staging you should know in the surgery. Now based on this, there can be stage 1, 2, 3 and 4. It is very easy. If it is T1, N0, M0, it is stage 1. If it is T2, N0, M0, is stage 2. If it is T3, N0, M0 or T1 to 3 anything, N1, M0, that is stage 3. And apart from this anything, if there is any T4, if there is any N2, if there is any N3, if there is any M1, all those will be stage 4. Okay, any T4, N2, N3, M1 will be stage 4. Okay, so now we will see what is the general principle of treatment in oral cavity cancer. Okay, general principle of treatment in oral cavity cancer. See, oral cavity cancers are squamous cell cancers. Squamous cell cancers are radiosensitive. So in these cases, these tumors, either you have two options basically, surgery or radiotherapy. So if it is stage 1 or stage 2, you can go for single modality treatment. Single modality treatment, that is either you do surgery or you give radiotherapy. Either of that. Although you prefer surgery, but suppose patient is not fit for surgery or the patient denies for surgery, then you go for radiotherapy. For stage 3 or 4, you will do surgery as well as you will give radiotherapy as well as you will give chemo. So multi-modality treatment in higher stages, single modality treatment in stage 1 or 2. Okay, this is the principle of treatment in this case. Now a little bit about reconstruction I'll tell you. Like carcinoma lip, when you do surgery, in these cases, see, carcinoma lip has the best prognosis among the oral cavity cancer. One reason is because of the early presentation. Okay, if there is any tumor on this part, the patient will come early and will get the treatment also quite early. So carcinoma lip, when you do the surgery, you will take 3 to 5 mm margin. 3 to 5 mm margin. So suppose Okay, let's see. Suppose this is the lip and there is a tumor. Okay, tumor mostly starts at the vermilion border. Most common site, vermilion border. Okay, vermilion border is the area where the skin ends and the mucosa starts, mucocutaneous junction. Okay, so 3 to 5 mm margin you will take and you will do the excision. After the excision, there will be a defect. Okay, there will be a defect like this. So, what are the options to close this defect? Okay, to close this defect, you can go for primary closure. Okay, you bring both the ends in the midline and do the closure. Or you can use local flaps. Okay, let me tell you the exact way that how it is done. Suppose this gap is less than 1/3 of the total length of the lip. This gap is less than 1/3 of the total length of lip, then you can go for primary closure. Primary closure means you bring both the ends and suture it like this. Suppose this gap is 1/3 to 2/3 of the length of the lip. Okay, length means suppose this is the total length. Suppose this is 9 centimeter and this gap is less than 3 centimeter. You can go for primary closure. Suppose this gap is 3 to 6 centimeter. Okay, less 1/3 to 2/3. And in that case, you can use local flaps. Local flaps means one of the type of local flap technique. I am sure you must have heard about it. That you create a flap from this part and bring it to this area and do the repair. So this type of flap is known as Ebb-Aslander flap. Ebb-Aslander flap. Okay, so this is one of the flap techniques. Other techniques are Karapandzic flap, Webster-Bernard flap, and Johnson step technique. Okay, among all this, I want you to remember Ebb-Aslander flap. So you know all the flaps are based on some vessel. Ebb-Aslander flap is based on labial artery. Okay, so this is how we do the reconstruction. Less than 1/3 of the total length, primary closure. 1/3 to 2/3 local flaps. And if it is more than 2/3, then we use a radial forearm flap. Means a part of the skin and the muscle is taken from the forearm and then it is put at the lip area for the reconstruction. Okay, so this is how we do reconstruction in carcinoma lip. The treatment principle is same. If it is stage 1 or 2, either surgery or radiation. More we have to go for surgery as well as radiation as well as chemo. Second, if you see cheek or the buccal mucosa tumor, most common site is angle of mouth. When we do surgery, the margin we take is 10 to 20 mm. Okay, 20 mm is the ideal margin, 10 mm is the minimum margin. So when you remove the tumor from this part, there is going to be a big defect in this. So the reconstruction is done by two main flaps. One is pectoralis major myocutaneous flap. PMMC is pectoralis major myocutaneous flap. which is based on pectoral branch of thoracoacromial artery. PMMC flap. Another, we can also use radial forearm flap. Radial forearm flap is based on the radial artery. Okay, yes, Nidesh, we'll take a break. Don't worry. Let me finish this part. Just okay, oral cavity cancer. Let me finish. Then we'll take a short break, and then we'll do salivary gland and the urology part. Okay, PMMC flap, which is based on pectoral branch of thoracoacromial artery, and radial forearm flap. Okay, and see, third we'll see tongue tumor. Okay, tongue cancer. Principle of surgery is same. Okay, principle of surgery is same. Just a moment. Something in my okay. Tongue cancer, suppose this is the tongue. So in the tongue cancer, there is these circumvallate papillae that divide the tongue into anterior 2/3 and posterior 1/3. Okay, so the most common site is anterior 2/3 lateral border. That is the most common site. Okay, posterior 1/3 cancer has very poor prognosis. Poor prognosis. It has very poor prognosis. Okay, so in tongue cancer, again, thus when we do the surgery, the margin we take is 10 to 20 mm. Okay, that is 10 mm is the minimum, 20 mm is the ideal margin. Reconstruction in relation to artery, Nishant, I'll tell you. Okay, let's see. See, suppose there is a patient. Okay, let me give you example. Suppose you have done a breast cancer. Okay, breast cancer you have done. So there is a defect on this part. So there are different flaps which can be used for the reconstruction. Okay, one flap you can take from here, that is tram flap. Another flap you can take from here, which is LD flap. So all these flaps, they have their blood supply. Okay, it is not like graft where you put it somewhere and then that graft will take the blood supply from the recipient area. Flap, they have their own blood supply. So when you are putting the LD flap at this area or the tram flap at this area, it will have its blood supply. Okay, so like in case of tram flap, it is inferior epigastric or superior epigastric artery. In case of LD flap, it is thoracodorsal artery. Okay, like when I am saying radial forearm flap, or suppose in this case pectoralis major myocutaneous flap. So suppose there is a defect here. Now you are putting this part here. So this pectoralis major myocutaneous, it is taking its blood supply from the thoracoacromial artery. I mean the pectoral branch of thoracoacromial artery. Or this radial forearm flap, when you are putting it here, it is taking its blood supply from the radial artery. Okay, so there are different types of flap. One is free flap. Free flap is you take from this area and you put it somewhere else. So in case of free flap, you have to do the anastomosis of that blood vessel with some recipient area blood vessel. But in case of pedicle flap where you just rotate it, so in that case you don't have to do the vascular anastomosis. So different areas like this tram flap can be used as a pedicle flap, it can be used as a free flap. Same goes for most of these cases. Radial forearm flap here is mostly a free flap, so you have to do the anastomosis here with the radial artery with some kind of recipient artery. Okay, so 10 to 20 mm margin. So when you take, suppose this is the tongue and you are taking like 10 to 20 mm margin, if you remove like this much, so if less than 1/3 of the tongue is removed, then it is known as partial glossectomy. Okay, if 1/3 to half of the tongue is removed, it is hemiglossectomy. If half to 3/4 is removed, it is near total glossectomy. And if more than 3/4 of the tongue is removed, it is total glossectomy. Okay, so after taking that much margin, how much of the tongue you have removed, based on that these are different names are given. And if we talk about the reconstruction, in partial glossectomy you have to just do a primary closure. Okay, just close it, you don't need any reconstruction as such. Hemiglossectomy, you can go for this radial forearm flap and a near total and total rectus abdominis flap. Rectus abdominis flap is based on inferior epigastric artery. Inferior epigastric artery. Okay, so till now we have covered thyroid, parathyroid, adrenal, Men's syndrome and oral cavity cancer. We'll take a break, 15 minutes, 15-20 minutes, and then we'll do just little bit of salivary gland and the important things of the urology. Okay, if you have any question, feel free to ask. Okay, any kind of question, please ask. Okay, so we'll take a break. Okay, it is I don't know what is the time in your clock. It is 5:40 in my this thing. So let's come after 20 minutes, 6 o'clock sharp. Okay, 6 o'clock sharp. I mean 20 minutes right from now. Yes, yes. Hi, welcome back. Okay, so now we will talk about one or two things of salivary glands. Okay, the first thing is there is a question comes on salivary gland about the ranula. Okay, ranula is a cystic swelling present at the floor of the mouth, and this is a mucus extravasation cyst of sublingual gland. Okay, mucus extravasation cyst, this is a important question. Treatment is excision. And another thing is there is something known as plunging ranula, where are two swellings. Ranula is inside the mouth, just under the tongue. Okay, so it is a mucus extravasation cyst of the sublingual gland. And plunging ranula, there is a swelling inside the oral cavity and outside also, in that mandibular area there is a swelling. So that is plunging ranula. Plunging ranula is a mucus retention cyst of sublingual and submandibular gland. Okay, so a simple ranula is a mucus extravasation cyst and a plunging ranula is mucus retention cyst. Of both sublingual and submandibular, treatment of this is also excision. Now silolithiasis. Silolithiasis is stone in the salivary gland duct. 90% is seen in submandibular gland and just 10% is seen in parotid. Okay, and submandibular stones are usually radio opaque, okay, which can be seen on X-ray, although the investigation is CT, but it can be seen on X-ray. Parotid is radiolucent, that cannot be seen on X-ray. Okay, are you back? Just tell me. Okay, Yusuf, Aishwarya, Rishika, Nishant, Aisha, Sozil. Okay, now we will see the main topic, salivary gland tumor. Salivary gland tumor. See, 70% of the salivary gland tumor you will see in parotid, 22% in submandibular gland, and just 8% in sublingual and minor. Okay, so you're back. Okay, break was at the right time. There is a match between India and Bangladesh, so India won that last over with around, I guess, 6 runs. Okay, now among this salivary gland tumor, what is the percentage of benign and malignant? Parotid. More than 80% of the time benign tumor, less than 20% there can be malignant. Submandibular and sublingual, 50% of the time benign, 50% malignant. And minor, 10% benign, 90% of the tumors are malignant. 90% are malignant. Okay, so if we talk about benign tumors, two important benign tumors, pleomorphic adenoma. In pleomorphic adenoma, see, this is the most common salivary gland or parotid tumor. Okay, site is usually superficial lobe of parotid. Although it is a benign tumor, but if you leave the tumor, if you don't do the surgery, then there are chances of malignancy. Okay, so 3 to 9% risk of turning into cancer. Okay, the treatment is superficial parotidectomy. Superficial parotidectomy. So see, the problem with the superficial parotidectomy is when we do the surgery, between the superficial lobe and the deep lobe, facial nerve is going. So while doing the surgery, one has to be very, very careful not to injure the facial nerve. Okay, so that's why there are certain landmarks to identify facial nerve during surgery. Landmarks to identify facial nerve. Okay, so in this landmarks, see the important, you can say the landmarks is stylomastoid mastoid foramen. Okay, when it enters into the face, tympanomastoid suture, posterior belly of digastric, tragal pointer is the cartilaginous part. Okay, and then you can come from periphery to main trunk. Or you can make a hole in the mastoid before it enters into the face. So you can say trephination of mastoid. Okay, so these are different landmarks to identify the facial nerve. And once you have identified the facial nerve, just remain above or superficial to the facial nerve and remove the parotid. It will be superficial parotidectomy. Okay, so one benign tumor, that is the most common, pleomorphic adenoma. Another benign tumor, there are many questions on this, Warthin's tumor, also known as adenolymphoma or papillary cystadenoma, lymphomatosum. These are different names of Warthin's tumor. So previously there were lots of questions they used to ask in the Warthin's tumor. There are just 4 or 5 points are there in the Warthin's tumor, and those 5 points are asked multiple times in the form of MCQs. Let's see, most of the salivary gland tumors are more common in males, but Warthin's is more common in females. It is associated with smoking. Okay, it is totally benign, there is no risk of cancer. Only in parotid. Bilateral in maybe in 10% of cases. And on a nuclear scan, this will give a hot spot. Rest of the tumors, they will give cold spot. Okay, so just these 6 points. No other questions apart from this in Warthin's tumor. Okay, malignant tumor. First we'll see mucoepidermoid carcinoma. Mucoepidermoid carcinoma, as the name suggests, it is made up of mucus cells and the squamous cells. This is the most common malignant, you can say overall this is the most common malignant salivary gland tumor and parotid tumor. And this is radiation induced. Treatment, if it is low grade, then superficial parotidectomy. High grade, total conservative parotidectomy. The meaning of total conservative parotidectomy means you will remove the superficial lobe, you will remove the deep lobe, but you will save the facial nerve. Okay, these days in any case you have to save the facial nerve unless the tumor is directly involving the facial nerve. Okay, so if the tumor is directly involving the or infiltrating the facial nerve, then in those cases you might have to take out a part of the facial nerve. Otherwise, in any given case, you try to preserve the facial nerve. Trephination of mastoid is so that you will make a hole in the mastoid and find the facial nerve before it comes from the stylomastoid foramen. Okay, before, otherwise mostly we try to find out here in front of the external auditory meatus where there is stylomastoid foramen. So in those cases when it is not possible to find out where is the facial nerve, so you can make a hole in the mastoid and find out the facial nerve there, and then you can trace it anteriorly up to this part and try to save the facial nerve. Second is adenoid cystic carcinoma. Okay, so this is the most common tumor of submandibular, sublingual and minor gland, and second most common malignant tumor of parotid. Second most common malignant tumor of parotid. So just one thing you should remember about adenoid cystic is that it has increased propensity to have perineural invasion, or it involves the nerve more frequently than any other tumor. Okay, perineural invasion. So facial nerve involvement is quite common in these cases. Okay, just remember this thing about adenoid cystic carcinoma. And treatment is mostly radical parotidectomy and radiotherapy. Most of the salivary gland tumors are radio resistant. This is relatively radiosensitive, so that's why we give radiotherapy. Radical parotidectomy means superficial lobe, deep lobe and a part of facial nerve if it is involved, and mainly in adenoid cystic carcinoma it is involved. Okay, so now we will see urology. Okay, so in urology, instead of going to all the different systems, we will talk in different headings. Like first we'll talk about the important congenital disorders related to urology, then we'll see about the stones, we'll see about the tumors, and then about some infection. Okay, like this we will see. So first we'll see congenital disorders. Okay, horseshoe kidney. Horseshoe kidney is a condition in which the lower pole, suppose this is right kidney, this is the left kidney, so poles of the kidneys are fused. Mostly the lower pole is fused, and that fused area is known as isthmus. Okay, and isthmus is mainly present at the L4 vertebra level. One more question they ask, we all know the kidneys, the development start in the pelvis and then they go upwards. So this horseshoe kidney is present not at the normal level but slightly lower down, because the ascent of the kidney is prevented by inferior mesenteric artery. Inferior mesenteric artery prevents the ascent of the kidney, horseshoe kidney. So horseshoe kidneys are functionally normal, but the problem is that the ureters are angulated. Okay, so the ureters are angulated. So because of the angulated ureters, sometimes there is stasis of urine, and because of this stasis there can be urinary tract infection, there can be stone, there can be hydronephrosis. Okay, so that's why when we do the treatment in case of horseshoe kidney, all we need to do is, if the patient is asymptomatic, then no treatment. Okay, many times the patient does not need any treatment, the whole life is gone. Last week only I did a surgery, there was a stone in the horseshoe kidney and the age of the patient was 80 years. So this is a congenital condition, for 80 years he was fine, so there was no treatment required. Now when he came to me there was a stone and hydronephrosis, so we did the surgery. Okay, so if asymptomatic, no treatment. If the patient is having symptoms, then all we need to do is just correct the angulation, so that is known as pyeloplasty. Okay, the isthmus of the horseshoe kidney is not divided. Okay, we don't have to divide the isthmus. isthmus is not divided. Okay, so these are the important things, and on the IVP this will give a flower vase appearance or hand joining sign. Pyeloplasty, Rohit, is the correction of that angulation. Okay, correction of that angulation of ureter, that is pyeloplasty. Okay, second congenital problem we'll see, that is duplication of pelvis or ureter. Duplication of pelvis or ureter. The meaning of duplication means from one kidney there will be two pelvis and two ureters. Two pelvis and two ureters. So that is the meaning of duplication. One important thing you should know in the duplication is, see, when these ureters come to the bladder, suppose this is how the lower pole ureter is opening into the bladder. Okay, this is the lower pole ureter, lower pole. This is the upper pole. So when the upper pole ureter comes, it will wind around the lower pole ureter and it opens distally and medially to the lower pole ureter. Okay, it opens distal and medial to lower pole ureter. So this is a rule. This is a rule which is known as Weigert-Mayer's rule. Weigert-Mayer's rule. And many times this ureter becomes ectopic. Okay, ectopic, okay, we'll see later, ectopic ureter. So this is Weigert-Mayer's rules. This is duplication of the pelvis or the ureter. On IVP, this gives a sign which is known as drooping lily sign. Okay, so this is duplication of pelvis or ureter. Now here only I will talk about ectopic ureter. Ectopic ureter means the ureter is not opening at its normal site, it is opening somewhere else. So mostly this is associated with duplication, and it is the upper pole ureter which is opening at a different area. So now see, first I'll tell you what is the problem in males. In males, you know, your urethra is long, there is prostate here. Okay, I'm not drawing the prostate. Just I'll tell you that this is the prostatic urethra. This is a membranous urethra, this is bulbar and penile urethra. And in males, there is a sphincter at the internal sphincter and one external sphincter. Okay, external sphincter, this is internal sphincter. In females, the urethra is short, like 4 centimeter, and there is just one sphincter. Okay, that is sphincter. So in case of males, the ureter comes and opens at the prostatic urethra or posterior urethra. In case of female, it comes and opens at the distal urethra. So now what is the problem in females? See, suppose one ureter is opening normally, another ureter is opening ectopically. So now what will happen? Now the urine which is coming from here, it is passing the sphincter, beyond sphincter, and the child will have continuous dribbling of urine. So there will be incontinence of urine. But in this case, when the urine comes here, there is a sphincter distal to that, so that will prevent the incontinence. So there is no incontinence in case of males. Just remember this thing about ectopic ureter. What is the site of ectopic ureteric opening in males and females, and how clinically it is different? In females it will lead to incontinence, in male it does not lead to incontinence. In males mostly it can lead to recurrent urinary tract infection. The treatment is you remove the ureter from here and put it back into the bladder. So we'll say ureteric reimplantation. Ureteric reimplantation. Okay. Next congenital condition we'll see, that is ureterocele. Okay, this is the, just tell me, this is the first surgery class or the other parts of the surgery has already been done? Because I don't have any idea. I was told to take this part. This is the first surgery class for you, or the other parts of the surgery has been taken, the general surgery part and the GIT hepatobiliary part? Okay, this is the first class. Okay, fine. I hope you are understanding something. Okay, see, this is crash course, so we cannot be very slow and we cannot tell each and everything. Okay, surgery, otherwise, if you see in the regular classes, surgery goes for up to like almost 80-90 hours, and that 80-90 hours we have to, we have to find out the important things and tell you in this 15 hours. So obviously there will be some difference. But if you are doing crash course, means you have the basic knowledge, and I'm sure you are getting my points. What I'm, treatment of double pelvis is also the same, Ankur. Okay, you have to do the asymptomatic cases, no treatment. Symptomatic cases, ureteric reimplantation if it is causing ectopic ureter. And sometimes in this upper part there is hydronephrosis. Okay, so then you have to go for partial nephrectomy. If there is hydronephrosis, partial nephrectomy. Otherwise, I have seen most of the cases are asymptomatic. This is very common. This is in fact the most common congenital anomaly of the upper urinary tract. Okay, this you might see in 1 in 150 live births. So very common condition, and mostly the patients are asymptomatic. Okay, so in ureterocele, see, this is the ureter which goes, then it enters into the bladder and travels for some distance in the bladder, and just before it opens into the bladder there is this dilatation. So dilatation of terminal part of the ureter is ureterocele. Dilatation of the terminal part of ureter. Mostly you get the question on ureterocele on IVP finding. IVP in these cases will show cobra head appearance. Cobra head appearance, adder head appearance, different names are given. Again, asymptomatic, no treatment. Symptomatic case, you would go with cystoscopy, and cystoscopically you can do the fulguration or just the ureteric meatus. This part of the opening is very small, so you just cut that opening and the ureterocele will be treated. Okay, so I'll say cystoscopic ureteric meatotomy. You'll cut the meatus, so this swelling will disappear. Where the ureter is opening into the bladder, you make that opening big and the problem will be solved. Ureterocele. Yes, Rohit, cobra head appearance. Next we'll see polycystic kidney disease. Okay, polycystic kidney disease. are two types: adult polycystic kidney disease and infantile polycystic kidney disease. Infantile polycystic kidney disease is autosomal recessive condition. Okay, the gene mutation is PHD1 gene, which is located on chromosome 6 and usually is not compatible with life. So many other congenital anomalies are associated. This is not compatible with life. Adult polycystic kidney disease due to mutation of PKD1 and PKD2. PKD1 on chromosome 16, PKD2 on chromosome 4. This is more common as compared to this. So the name is adult polycystic kidney disease. This is autosomal dominant because the presentation is in adulthood. Okay, the disease starts in the children because there are initially small cysts. As these small cysts, they will enlarge, they will compress the surrounding renal parenchyma, and ultimately the renal parenchyma will be gone and the patient will have renal failure. Okay, so clinically, if we see, the presentation is usually in 30 to 40 years, more common in females, almost always bilateral. Okay, the patient will have pain, hematuria, mass, and like I said, sooner or later patient will have renal failure. IVP will show spider leg appearance. Okay, spider leg appearance, although the investigation of choice is CCT, abdomen. Okay, so one more question they ask, what are the associated anomalies? Okay, this is a congenital condition, so there are certain anomalies which you will find very commonly associated with polycystic kidney disease. That is multiple cysts in liver, pancreas, spleen. Most common is this liver. Okay, berry aneurysm. Then diverticulosis of colon, mitral valve prolapse, okay, hepatic fibrosis. So there are other anomalies also seen in polycystic kidney disease. Yes, I'll try to upload all these images, IVP and the important CTs and other things. Treatment is sooner or later patient needs renal transplant. Renal transplant. Okay, then congenital PUJ obstruction. PUJ is pelviureteric junction. Okay, like this is pelvis, and this is PUJ obstruction. Okay, so cause of this is sometimes in this part there is no peristalsis. So there is a peristaltic segment. Sometimes the ureter is highly, or you can say abnormally inserted on the you can say the pelvis. So high insertion of ureter on pelvis. And sometimes there is an abnormal lower pole vessel which will compress the pelvic junction. Okay, abnormal lower pole vessel. So any of these conditions can lead to congenital PUJ obstruction. The patient will have hydronephrosis. I mean, the child will have hydronephrosis because of the back pressure changes. Investigation, basically we do ultrasound is one. Investigation of choice. We need to see the function of the kidney, whether this kidney is functional or not. And you all know for function of the kidney, we go for DTPA scan. Or for children these days, there is a new scan, MAC3 scan, to see the function. There is one question asked recently. There is a type of test which is known as Whittaker test. Okay, what we do in Whittaker test, okay, suppose there is some obstruction here, PUJ obstruction. So we put two catheters. One catheter we put in the pelvis, and one catheter we put in the bladder. So this we see the pelvic pressure of the pelvis, and this we see the vesical pressure. Okay, so in Whittaker test, normally also the pelvic pressure is more than the vesical pressure. So normally pelvic minus vesical pressure is around, you can say, less than 13 centimeter of water. If this is more than 14 to 22, then it is known as mild to moderate PUJ obstruction, and more than 22 it is severe PUJ obstruction. No, cyst does not form in the transplanted kidney, Ashwarya. It does not form in the transplanted kidney. Okay, because that was congenital. That thing happened during the development of the kidney. Few urinary ferrous tubules, you can say, when there is tubules, they fail to join with the collecting duct. So those tubules which fail to join with the collecting duct, they form the cyst. Okay, when you are giving some new kidney, in that there is already everything has been developed, so it will not turn into cyst. Okay, so in transplanted kidney this will not happen. Treatment is, just remember one surgery, the name of one surgery. Okay, you will remove this part, this abnormal part, and join the normal thing. So this is known as Anderson-Heinz dismembered pyeloplasty. Anderson-Heinz dismembered pyeloplasty. Okay, so this is congenital PUJ obstruction. Next thing we'll see of the bladder, ectopia vesicae. Ectopia vesicae is a condition in which this is a condition in which the bladder condition. Okay, the anterior abdominal wall, suppose this is a newborn child. So below the abdominal wall, below the umbilicus, the anterior abdominal wall is absent, and you will see directly the bladder in this part, and in bladder also the anterior wall of bladder is also absent, and directly you can see the ureteric opening through which the urine is coming out. Okay, so you can say absence of infraumbilical anterior abdominal wall with absence of anterior wall of urinary bladder. And also in these cases you will see epispadias. Epispadias is a condition where there is abnormal urethral opening on the dorsal surface. Abnormal urethral opening on dorsal surface of penis. Okay, so this is a very severe, you can say, congenital anomaly related to the bladder, but luckily not very common, seen in 1 in 50,000 live births. And this condition increases the risk of adenocarcinoma of the bladder. Treatment these days, people they are doing modified stage repair of extrophy or ectopia vesicae. Modified stage repair. Stage repair of ectopia, which is also known as extrophy of the bladder. So what is modified stage repair? In around 72 hours after the birth, you close the bladder, repair the bladder and the anterior abdominal wall. At around 18 months, you do the surgery of, close, here you write repair, surgery of epispadias, and at around 5 years, you will do the bladder neck repair, because these kids they will have incontinence of urine. Even if when you close the bladder and the anterior abdominal wall, the child cannot hold the urine, so it will keep on coming. So for that incontinence bladder neck repair you will do at around 5 years of age, when the child becomes 5 years of age. So just remember these things, nothing else from ectopia will be asked. Okay, then another congenital condition related to the urethra and the penis is hypospadias. Hypospadias is a condition in which, suppose this is the penis, so there is abnormal urethral opening on the ventral surface of the penis. Urine comes from here. Abnormal urethral opening on ventral surface. Okay, so there are different locations where this urethra openings, like if it is opening at this part, that is granular. Here it is coronal. This and this is penile. It can open in the scrotum, scrotal, or it can open way proximally in perineum. So these are the different sites of hypospadias, although most common is this granular and coronal. These are known as anterior hypospadias. This is the most common. Penile is mid, and scrotal perineal are posterior hypospadias. Okay, so the problem with this is, now see, this part is the part where the urethra should have gone, which has not gone. Okay, this part. So there will be fibrosis in this part, and because of the fibrosis the penis will deviate, or you can say it will turn inferiorly from this part. Okay, this was the opening. So distal to the opening the penis will turn inferiorly or ventrally, and that is known as ventral chordae. Ventral chordae. And now also there will be a additional prepuce on that side, This is ventral chordae, and this additional prepuce is hooded prepuce. Hooded prepuce. Okay, so this needs surgery. Surgery should be done in 6 months to 12 months period duration, or you can say timing of the surgery. Ideally, this is the time between 6 months to 12 months one should do the surgery. So there are different names of the surgery, but we need to see basically what is the basic principle of the surgery. Principle of the surgery is, first we need to make the penis straight. So that is known as orthoplasty. Okay, make the penis straight. The opening is here. Suppose you have removed the opening. Now the next thing is, you have to make this urethra go up to this part. Okay, so that is urethroplasty. Okay, so many times people, they take different things to form that urethra. Okay, buccal mucosa, skin from the prepuce, from the scrotum. So that's why this the circumcision is contraindicated in hypospadias, because you need this part for that. Buccal mucosa, prepuce can be used to make this part of the urethra. And then you have to give glans its shape, so that is granuloplasty. Okay, give the shape of the glans. So that becomes the complete surgery. Okay, and this question has been asked 2-3 times. What is the sequence? Orthoplasty, urethroplasty, and then granuloplasty. Okay, this is hypospadias. Another congenital condition related to urethra, we'll see, that is posterior urethral valve. Posterior urethral valve is seen only in males. Suppose this is the bladder and this is the urethra. So this is prostatic, this is membranous, bulbar, and penile. So in the posterior urethra, that is prostatic, membranous, or the junction of prostatic and membranous, there is this valve. These are these valves. Most common location, prostatic urethra, just distal to verumontanum. So verumontanum is present at the distal part of the prostatic urethra. So these valves are present just distal to verumontanum, although it can be seen above the verumontanum, below the verumontanum, but the most common is just distal to verumontanum. So the important thing about this valve is, if you are putting something from below upwards, then it will open and it can easily go. Suppose you want to put catheter, catheter will easily go without causing any obstruction. But if something is coming from above downwards, then these valves will close. Okay, it will not let the urine come freely, so it will close. So it has one-way obstruction. One-way obstruction. Below upwards it will open, but above downwards it will close. Okay, thing can go easily below upwards, but above downwards it will cause problem. Okay, so not a very big problem to treat. Treatment wise, we will do the cystoscopy and we will destroy these walls by using cautery. Suppose these are the walls, so we'll come and see the wall and just destroy the wall. The treatment is done. So that is known as cystoscopic fulgration of the valve. Cystoscopic fulgration of the valve. Okay, last congenital condition, that is undescended testis. Undescended testis or UDT. Undescended testis. So if we see, normally when the development of, during the development, or rather during the, suppose this is the inguinal canal, this is the abdomen. So when the testis, developing testis descends down, so at around 7th month of intrauterine life, 7th month of intrauterine life, the testis is present at the deep ring. At 8th month, it travels in the inguinal canal. At 9th month, it is in the superficial ring. And just before birth, it comes into the scrotum. It comes into the scrotum. So this is the normal descent of the testis. There are lots of factors, testosterone and the Mullerian inhibiting factor, lots of factors which helps in the descent of the testis. There is something known as gubernaculum that also helps in the descent. So if this testis does not descend down, what problem it can lead to? Okay, what complication it can cause if it does not come into the scrotum? Okay, the mnemonic for that is testis only. It can lead to torsion of the testis, inflammation that is known as epididymo orchitis, sterility if bilaterally the testis does not come down, trauma in the inguinal canal occurs, inguinal hernia, and very important, malignancy. Okay, there are 40 to 50 times higher chances of getting a seminoma in an undescended testis as compared to a normally descended testis in the scrotum. Okay, so up to 3 months, spontaneous descent. Okay, so suppose a couple comes with their newborn male child and they says that the testis is not in the scrotum, then you can easily tell that couple that okay, up to 3 months there are high chances that it will come on its own. If it has not come down by 3 months, there are chances that it will not come down. So you will do the treatment. Treatment means surgery. In surgery, orchidopexy is done. Ideal timing is from 6 months to 12 months. Okay, do not delay beyond 12 months, because if you delay beyond 12 months, there will be permanent changes starts in the testis. Okay, and the surgery is bring the testis down and fix it with the scrotal wall. So that is known as orchidopexy. Most of the time you will find the testis in the inguinal canal only. So you just explore the inguinal canal, you will find the testis, bring it down and fix it with the abdominal wall. Yes, undescended testis can go into torsion because it is not fixed. It is not fixed. Okay, so if the testis is not fixed, it can rotate. Okay, it can rotate in the inguinal canal. It can cause torsion in the inguinal canal. Okay, Rucha. The layers, those tunica vaginalis, those layers are not fixed with the, otherwise normally those things, they are attached in the scrotum with the dartos muscle and hence it does not rotate mostly. There are certain predisposing factor where it can rotate, but otherwise mostly does not rotate. If it is present in the inguinal canal, it is quite free and it can rotate, it can cause torsion. Okay, so these are different important congenital anomalies which you should know in the urology. Next we'll see the stones. Okay, renal stone, ureteric stone, bladder stone. Okay, so Now we'll see renal or ureteric stones. Okay, no stone will form in the ureter. If there is a stone in the ureter, means it has come from the kidney only. It cannot form in ureter. It is dropped from the kidney. Okay, so first we'll see what are the different types. Okay, calcium oxalate, triple phosphate, uric acid, cysteine, xanthine. These are the common types. Then there are certain drug induced and very rare type. Calcium oxalate is most common. It can be calcium oxalate monohydrate or dihydrate. Monohydrate stone, if you see in the urine, if you see the crystals, you will see these dumbbell shaped crystals. And dihydrate, you will see this envelope shaped crystals in urine. Okay, and calcium oxalate, it forms in, okay, let's make it simple. Triple phosphate, I'll tell you the important things. Calcium, magnesium, ammonium phosphate, which is also known as struvite or staghorn calculus. Okay, its crystals in the urine are like this coffin lid shaped crystals. Okay, uric acid, you can say amorphous crystals. Cysteine, you can see hexagonal crystals. Xanthine, there is no shape as such. Now we'll see calcium oxalate, uric acid and cysteine. They form in acidic urine. Triple phosphate forms in alkaline urine. In xanthine, the pH of the urine is not important. Okay, it can form in acidic, it can form in alkaline, it can form in neutral pH. This class is still 8 or maybe 8:15 max, 8:15, 8:30. I'll try to finish by 8:15. Okay, Vrinda. Now remember one more mnemonic, remember lux. L is lucent. Radiolucent is uric acid and xanthine. Rest stones are radio opaque. Okay, other stones are radio opaque. Clinical feature. Okay, clinical feature depends on the location. Okay, suppose the stone is in the kidney and pain in the flank. Okay, renal angle just below the 12th rib. Stone in the upper ureter. Pain radiates to testis. Testis in case of males or labia majora in case of females. Mid-ureteric calculus, pain in the iliac fossa. Lower ureteric calculus, pain in the medial aspect of thigh. Okay, so these are the sites of pain depending on the location of the stone. Investigation of choice is non-contrast CT KUB, NCCT KUB. Okay. Now we'll see the treatment. Okay, there are four options basically. There can be spontaneous, you can say regression. Spontaneous passage for stone up to 6 mm. Stone up to 6 mm, there are high chances that it will pass on its own. Okay, then ESWL, extracorporeal shock wave lithotripsy. So in extracorporeal shock wave lithotripsy, shock waves are focused on the stones, and suppose these are the waves focused, and this will break the stone into multiple small fragments and they will pass. Okay, so ESWL is ideal for less than 1 centimeter stone, maximum 2 centimeters. So up to 2 centimeter stone you can try ESWL, but for less than 1 centimeter it is ideal. There are certain types of stones which are very hard. So stones resistant to ESWL, cystine stone. Cystine stone is very hard. It will, these rays will not break those stones. Calcium oxalate, monohydrate. These two are the important. Then you can say there is a type brucite, hydroxyapatite. These are mixed type of stone. It has calcium phosphate, calcium oxalate. So this slide you are asking, Sozil. Okay, so these are the stones. These types of stones, they are resistant to ESWL. Then another technique is PCNL, where we suppose this is a stone. So we make a track between the skin and the pelvic calyceal system, and through this track we'll go break the stone and take it out. Okay, through this track we'll go and break the stone and take it out. Percutaneous nephrolithotomy, PCNL. So this can be done for stone basically more than 2 to up to 3 centimeter. Then for ureteric stone, suppose there is a stone in this ureter, so you can do the cystoscopy and then you go through this ureteric opening and catch hold the stone and take it out. This is known as ureteroscopic removal of stone, and this is known as Dormia basket. Okay, so URS is mainly for ureteric stone. So now, because of the advent of the flexible type of ureteroscope, what people they are doing is they are putting those flexible ureteroscope and they are going up to the kidney to take the stone, and that technique is known as retrograde intrarenal surgery, RIRS, retrograde intrarenal surgery. Okay, उसके ऊपर कौन सी स्लाइड है सोजिल? This slide, this. Okay, so retrograde intrarenal surgery. So Now if we see, okay, so these are different options: ESWL, PCNL, URS, RIRS. These are different options for the treatment. Now we'll see size wise. Okay, less than 1 centimeter. Ideal is ESWL. 1 to 2 centimeter. Either ESWL or RIRS. More than 2 centimeter. PCNL. PCNL. Okay, sometimes when the stone is very big, okay, for the large staghorn calculus, okay, maybe 3 centimeter, 4 centimeter, then what we do is first we do PCNL and try to break the stones as much as possible. Then we do ESWL and we'll break the stone further, and if anything remains then we do PCNL again and take out those stones. So this is known as sandwich technique for large staghorn calculus. RIRS is retrograde intrarenal surgery. Okay, this is the indication: 1 to 2 centimeter stone in the kidney. 1 to 2 centimeter stone in the kidney. Okay, retrograde means you are going from below upwards. Intrarenal surgery. For ureteric stone less than 5 mm, spontaneous passage. Okay, ask the patient to drink plenty of water and it will pass. 5 to 10 mm, either ESWL or you can go for medical expulsive therapy. More than 10 mm, URS. What is medical expulsive therapy? So these are few drugs which we give so that the ureteric muscle will relax and there are chances of passage. Okay, I'll repeat everything again, Sozil, just a moment. In medical expulsive therapy, we give like tamsulosin or maybe calcium channel blockers or PDE5 inhibitors like sildenafil. Okay, so it will relax the smooth muscle and it will help in passage of the stone. Just last thing about the stone and then I'll repeat the whole thing. Stones in pregnancy. So first thing is, here the investigation of choice is MRI, because CT is contraindicated, so we'll go for MRI. Although ultrasound will do initially, if ultrasound is not helpful, we can go for MRI. Very important, ESWL and PCNL are contraindicated. So only option of treatment in these cases is either you go for URS or you go for RIRS. No other option. Okay, ESW and PCNL both are contraindicated. Okay, so this is in a nutshell the important things about the stones. Okay, so now tell me what you want me to repeat again. These are different types of stones: oxalate, triple phosphate, uric acid, cysteine, xanthine. Okay, the crystal shape, which is radiolucent, the symptom depending on the site of the stone, spontaneous passage in kidney up to 6 mm. Other options, ESWL, which is ideal for less than 1 centimeter, but yes, up to 2 centimeter you can do it. There are certain stones which are resistant to ESWL. PCNL is when you create a passage between the skin and the pelvic calyceal system, and using that passage you will put the instruments and take out the stone. URS is when you put a flexible ureteroscope through the bladder into the ureter and hold the stone using the Dormia basket and take it out. RIRS is the same technique, but instead of ureter you will go up to the kidney and take out the stone. Retrograde intrarenal surgery. So for less than 1 centimeter, ideally is ESWL, more than 2 centimeter PCNL, 1 to 2 centimeter either ESWL or RIRS. Large diagonal calculus, first you will do PCNL, then ESWL, and if anything remains, again PCNL. For ureteric stone, less than 5 mm, spontaneous passage, 5 to 10 mm, either ESWL or medical expulsive therapy. In medical expulsive therapy, you will use tamsulosin, calcium channel blockers, or sildenafil like PDE5 inhibitors. More than 10 mm URS. In pregnancy, MRI should be the investigation of choice if ultrasound is not helpful, because X-ray and CT scan we cannot do. ESW and PCNL are absolutely contraindicated. So URS and RIRS are the treatment options left in the pregnancy. Okay, now if we see urinary bladder stone. Sandwich, this is technique, not test, it is technique. Okay, that first you do the PCNL, try to break the stone, because initially you cannot break the stones into many small fragments, so you try to break a big stone into small few stones. Then those small stones you will put ESWL to make those small stones into fragments. So those fragments which can pass, it will pass, and if anything is remains, you will do the PCNL and take out those remaining segment. Okay, so that is Nishant sandwich technique. It is not test, it is technique. Bladder calculi can be primary, secondary, and migratory. Migratory, which is formed in kidney and dropped in urinary bladder. Okay, example, calcium oxalate. Secondary is which is formed due to infection. Okay, formed in the bladder due to infection, bladder outlet obstruction, foreign body, diverticula. Most common, uric acid followed by triple phosphate. And primary is which is formed in sterile urine without any anatomical abnormality. Okay, so these are rare, usually seen in children less than 10 years. Mostly those children who have low protein, high carbohydrate diet. Most common, ammonium urate. Most common, ammonium urate. And suppose this is a stone. These days open surgery for the bladder stone nobody is doing. People mostly going cystoscopically and doing the treatment. Okay, cystoscopic, removal of stone. If the stone is big, they break the fragments by using laser or mechanical lithotripsy. So basically they break the stone into multiple small fragments, and then using the cystoscope they will take out the stone from the bladder. Okay, so this is about the stones. Okay, anything if you want to ask? Now we'll see the injuries. Renal injury, renal trauma. Okay, so renal trauma, there is a grading that is known as AAST grading. Grade 1 is non-expanding subcapsular hematoma. Non-expanding subcapsular hematoma. Grade 2 is non-expanding perirenal hematoma, or if there is, like, see, this is, okay, I'll show you in different form, or if there is cortical laceration less than 1 centimeter. If there is only hematuria, that comes in grade 1. Grade 3 is cortical laceration more than 1 centimeter, but not reaching the collecting system. Grade 4 is any expanding hematoma. Okay, if there is a laceration more than 1 centimeter reaching up to collecting system. So when it reaches up to the collecting system like calyces or pelvis, there will be urine leak. This will cause urine leak. Or a contained renal vessel injury. So there is renal vessel injury, but not the complete injury. Little bit of tear. And grade 5 is hilar avulsion or shattered kidney. Okay, so this is the grading. Now before grading, just see one thing. Renal injury. If the patient is hemodynamically unstable, okay, means there is tachycardia, hypotension, then you will do surgery. In surgery, you will do nephrectomy. If the patient is hemodynamically stable, then you will go for CCT. CCT will tell you this AAST grading. Now after you have done AAST grading, now what you are supposed to do? Okay, now what you are supposed to do, if it is grade 1, 2 or 3, then non-operative management, or you can say conservative management. Non-operative management. If it is grade 5, nephrectomy. If it is grade 4, then either non-operative management or urinary stenting or nephrectomy. So that depends on patient to patient. That depends on patient to patient. Before renal vessel injury, contained. Okay, it is written contained. Means there is, suppose this is a vessel, so there is just little bit of injury which has caused hematoma in this area. Okay, that is contained renal vessel injury. So this is about renal trauma. Unstable, nephrectomy. Stable, get the CT done. CT will tell you AAST grading, and based on the AAST grading, further what is supposed to be done. Next is ureter injury. Ureteric injury does not usually occur during the trauma per se. Ureteric injury occurs iatrogenically when you are doing some lower abdominal surgery and the surgeon does not identify that it is ureter and somehow it gets injured. Okay, so it is mostly iatrogenic. Okay, so that's why in the lower abdominal surgery it is very important to identify ureter, and people mostly identify ureter by looking at the peristalsis in it. Okay, so now we'll see, suppose there is injury and there is no loss of length. No loss of length. So you will do, for unstable patient in any case, Sozil, you will always do surgery. Unstable patient means the patient is dying. You have to save the life of the patient. So you need to remove kidney, if you need to remove spleen, remove spleen. Unstable patient means you have to do nephrectomy. You don't have to think twice. Okay, you will do a end-to-end repair, and also you will put a degestant. First you will put degestant and you do end-to-end repair. Okay, if there is no loss of length. If there is little loss of length, then there are two options. One is you mobilize the bladder and bring it close to that ureter. Okay, and then you fix the bladder on the psoas muscle, that is known as psoas hitch. Another option is you will create a flap from the bladder wall and put it there and do the anastomosis with this ureter, that is known as Boari flap. Okay, psoas hitch or Boari flap. If there is significant loss of length, then you have two options. Either you bring something in between and do the anastomosis, like suppose this thing, maybe a appendix interposition, appendix or ileal loop. Boari flap using the bladder wall. Or another option is when there is significant loss, so you do the anastomosis of this ureter with the other side ureter. So that is known as transureterosterostomy. Okay, so these are the different options for the treatment of ureter injury. Okay, next we see the urinary bladder injury. Urinary bladder injury. See, the bladder is like this, and only on the dome of the bladder the peritoneum comes. Okay, so this is the peritoneum and above it the peritoneal cavity. So there are two types of injuries. one injury which can occur at the dome of the bladder, and the urine will go in the peritoneal cavity. So this is intraperitoneal rupture of the bladder. This is less common. Another is when the injury occurs in this and the urine collects around the bladder. So that is extraperitoneal rupture. That is more common. Okay, so intraperitoneal rupture occurs because of the direct blow or the direct trauma on the distended bladder. So what will happen when the bladder ruptures and the urine goes into the peritoneal cavity? There is peritonitis. Okay, there is lower abdominal pain. Patient will have tachycardia, hypotension. So in these cases, the treatment is you have to do a laparotomy, do the peritoneal lavage, wash the peritoneal cavity, and repair the bladder. Extraperitoneal rupture, on the other hand, in this case there will be associated with the pelvic trauma, associated with the pelvic fracture, and the urine will collect in the perivesical space. Okay, so there will be no peritonitis. Treatment in these cases is just do the catheterization. Catheterization of urinary bladder, and mostly the injury will heal on its own. You don't have to do any special treatment in these cases. Okay, the injury will heal on its own. Okay, so that is intra and extraperitoneal rupture. Another thing we'll see, another injury is urethral injury. Urethral injury. Okay, so in urethral injury, just a moment. Two types of urethral injuries there. One is bulbar urethral injury. Another is membranous urethral injury. Bulbar and membranous urethral injury. The treatment of intraperitoneal rupture, Harman, is always you need to do surgery, do the peritoneal lavage and repair the bladder. In case of extraperitoneal, no, Aishwarya, you can put a simple Foley's catheter also. You don't have to put a suprapubic catheter. If the urethra is fine, you can put the catheter through the urethra. It is absolutely okay. Okay, you can put the catheter through the urethra. Bulbar is more common. In this, the mechanism of injury is direct injury to perineum, which is known as straddle or fall astride injury. Membranous is fracture of the pelvis. In both the cases, there will be unable to pass urine, blood at tip of meatus. But in bulbar urethral injury, there is superficial perineal or butterfly hematoma. In case of membranous, there is deep perivesical hematoma. Perivesical hematoma. and in this there will be high in membranous injury, high lying prostate, that is known as Vermeulen sign. Treatment of both is, although same treatment is, do not put a Foley's catheter, do a suprapubic catheterization, then do the retrograde urethrogram to see retrograde urethrogram, and few people they do micturating cystourethrogram also. Okay, don't get confused. Retrograde urethrogram, you will know where is the injury, and then a delayed repair urethroplasty, mostly after 2 months to 2 to 3 months. Okay, so suprapubic catheter, retrograde urethrogram, and delayed repair. Okay, so these are about the injuries. Okay, so we have seen the congenital anomalies, we have seen the stones, we have seen the injury. Now we'll see the tumors of the urinary system. Penile tumors pe mostly you don't get the question, so basically we'll see the renal tumor, we will see the bladder tumor, prostatic tumor, testicular tumor. These are the 4 tumors we'll see. Tumors of the urinary system. Delayed because at that time, Aishwarya, if you try to do surgery because of the injury, there will be lots of edema, lots of inflammation. So at that time, if you try to do the suture, the things are friable and your suture will not hold. So that's why it is better you wait for some time, you let the edema resolve, let the inflammation get settled, and then you do the repair. Okay, till that time the patient will pass the urine through the suprapubic catheter. Okay, first we'll see RCC. Risk factor, basically smoking, obesity. Okay, then there are certain like polycystic kidney disease also increases the risk a bit, but there are certain syndromes. Okay, so I want you to remember these syndromes which are associated with clear cell RCC. Clear cell type of RCC, what are the syndromes associated? Because these kind of questions are very commonly asked these days. VHL syndrome, PAP1 mutant disease, and STH associated RCC. Then papillary type of RCC, the syndromes associated: hereditary leiomyoma and RCC syndrome, hereditary papillary RCC syndrome, then multiple tumor types. Okay, so Burt Hogg Dube syndrome, tuberous sclerosis, Cowden syndrome. Okay, so these are some of the syndromes associated with RCC. So these kind of questions are very common. All of the following syndromes are associated with RCC except. Okay, so clinically RCC will have pain, hematuria and mass. Investigation of choice is CECT. Any kind of FNAC or biopsy is not done. Now see, the treatment is, I'll not go into the staging because that is not very important. Okay, should I tell you or not the staging? Staging important is in prostate cancer, it is in the bladder cancer little bit, and in the testicular cancer. So here I'll skip the staging. I just basic things I'll tell you, that there are two types of treatment. Either you do a partial nephrectomy, which is also known as nephron sparing surgery. Nephron sparing surgery or partial nephrectomy, or you go for radical nephrectomy. So partial nephrectomy you will do in tumor less than equal to 4 centimeter. That is okay, I'll write T1A tumor. Bilateral RCC. Familial syndromes. And single functioning kidney. In these cases you will go for partial or nephron sparing surgery. Rest from T1B to T4 you will go for radical nephrectomy, where you will remove the whole kidney as well as ureter. Breast cancer stage is very, very important, Rohit. That is one of the most, I mean, if you ask me one TNM staging to remember in the surgery, it is breast cancer staging. Okay, it is breast cancer staging. So just remember this much about the, renal cancer. When to go for partial nephrectomy, what are the syndromes associated? That's it. Next, urinary bladder cancer. Now, bladder cancer, there are three types. Adenocarcinoma, squamous cell cancer, and transitional cell carcinoma. Most common is this, more than 90% is this. This is approximately 5%, this is just 2%. Must do staging, like I said, breast cancer, okay, and the oral cavity cancer. In the urology, mostly the staging you need for the treatment purpose, but yes, if you ask me which is must to remember, it is testicular cancer. In GIT, colorectal cancer. Okay, otherwise you don't need to remember the staging per se. If at all everything you find it is very difficult, please at least remember the breast cancer staging. Okay, breast cancer staging is one of the most important staging. Okay, next, in adenocarcinoma, the risk factor is ectopia vesicae or the patent urachus. Squamous cell cancer, bladder stone, bladder diverticula, and schistosomiasis. Transitional cell cancer risk factor, smoking, aniline dyes, like those worker benzene dyes who are working with dye industry, rubber, paint, leather industry. Cyclophosphamide, radiation, and schistosomiasis can lead to transitional cell cancer also. Okay, so these are the risk factors for Yes, colorectal cancer, that is what I am saying, Rohit. In GIT, colorectal cancer, hepatobiliary system, nothing much is important about the staging. And GIT, colorectal cancer, colon, rectum, same staging. And in urology, like I said, testicular cancer is important, prostate cancer, just two. Okay, breast cancer is the most important. Okay, clinical feature, patient will have painless gross hematuria. Painless gross hematuria. Now I'll tell you the staging here, but this staging you don't have to remember it as such. Just I'll tell you what is the thing you should remember. TIS is carcinoma in situ. TA is non-invasive papillary tumor. T1 is involvement of lamina propria. Lamina propria is the mucosa. So just remember, this is non-invasive bladder tumor. Then T2 is detrusor muscle involvement. T3 is perivesical fat involvement. And T4 is adjacent organ involvement. These are invasive tumors. Okay, so just remember what is up to the mucosa, it is non-invasive. If it goes beyond mucosa, it is invasive. Treatment of non-invasive, that is TIS, TA and T1. So you don't have to remove the whole bladder. Suppose this is the tumor inside. So you'll do the cystoscopy, come inside and take the tumor by taking multiple small pieces. So that is known as transurethral resection of bladder tumor, TURBT. Transurethral resection of bladder tumor. So after you do this, you'll have two types of tumor: low risk and high risk type. Low risk is TA tumor, low grade, less than 3 centimeter. High risk is T1, TIS and more than 3 centimeter TA, or high grade TA. So if the patient belongs to low risk, till now you have removed just the tumor. Further treatment is give single instillation of intravesical chemo. Single intravesical chemo. Inside the bladder, just fill once a chemotherapeutic agent like mitomycin C or gemcitabine. There are other drugs also, but these are the commonly used drugs. If it is high risk, then you have to give intravesical immunotherapy. Intravesical immunotherapy. In immunotherapy, you will give BCG. BCG start 2 to 4 weeks after TURBT and give every 6 weeks up to 1 to 3 years. So for next 1 to 3 years, mean at least 1 year, ideally 3 years, you call the patient every 6 weeks, fill the bladder with BCG, let it be there for half an hour to 1 hour, then release it, tell the patient to come again after 6 weeks. So that is intravesical immunotherapy. Yes, Ashwarya, correct. For invasive bladder tumor, invasive, first you give chemotherapy and then surgery plus radiotherapy. Surgery you will do is radical cystectomy. Radical cystectomy, where you will remove the bladder as well as the surrounding lymph nodes, and in case of females many times you need to remove the uterus also. Okay, so this is the treatment of the bladder tumor. Okay, any question you want to ask in this bladder tumor? When to go for non-invasive, I mean when to go for TURBT and when to go for radical cystectomy. Okay, is it clear? Now we'll see the third tumor, testicular cancer. Okay, testicular cancer, most common is seminoma. Then there are certain non-seminomatous germ cell tumor like teratoma, choriocarcinoma, yolk sac tumor, embryonal cell carcinoma. Low grade means histologically when it is well differentiated. Okay, it is histologically, pathologically if it is well differentiated. High grade means poorly differentiated. Okay, this you know when you do the biopsy. Biopsy will tell you it is low grade or high grade. Okay. And testicular cancer, clinically the patient will have basically testicular mass. Investigation, the best is, because mostly the testicular masses are cancer, so we will do a high inguinal orchidectomy. So this is the investigation as well as the surgery. Radical high inguinal orchidectomy you will do. Now you send that testis for the histopathological examination. What you are not supposed to do is, okay, transscrotal means through the scrotum, any kind of FNAC or biopsy is contraindicated. Okay, do not go through the scrotum because then it will leave a different set of lymphatic drainage channel. So any kind of FNAC or biopsy is contraindicated. Don't go through the scrotum. High inguinal orchidectomy, and now after that when you send the specimen for histopathology, you will come to know whether it is seminoma or non-seminoma. Okay, so what is the treatment you are supposed to do? First, let me tell you the staging. Okay, here the staging is important. Okay, send the specimen for histopathological examination. Histopathological will give the staging also. T1 is limited to testis without lymphovascular invasion. LVI is lymphovascular invasion. T2 is limited to testis. Okay, the first one is without lymphovascular invasion. This is with lymphovascular invasion, or if there is involvement of tunica albuginea or epididymis, that is T2. T3 is involvement of spermatic cord. Although it is not difficult, this staging is not difficult. T4 is scrotum involvement. So T staging is very straightforward. Spermatic cord T3, scrotum T4, only testis, no surrounding lymph node or vessel T1, surrounding lymph node vessel T2, or albuginea epididymis T2. N1 is lymph node less than 2 centimeter, N2 is lymph node more than 2 to 5 centimeter, and 3 is more than 5 centimeter lymph node. Okay, M0 is no distant metastasis, M1 is distant metastasis. Okay, so this is TNM staging, very simple, you can say 6 cycles, not 6 cycles weekly, Harman, it is every 6 weeks. Suppose I am giving on 15th September, then I'll call the patient on 1st November. And then after 1st November, I'll call him on 15th December. Okay, every 6 weekly you call the patient and put the Foley's catheter, put the BCG, let the BCG in contact with the bladder for 1 hour, remove the catheter, let the patient, let the BCG drains out and send the patient back. Okay, so it is not 6 cycles weekly, it is 6 weekly, you give 1 cycle. Okay, for staging, stage 1 is T1 to T4, N0, M0, and stage 2A, 2B, 2C, it is NET, N1, N2, N3, M0. Stage 3 is NET, NEN if it is M1. Okay, so this is the staging. Now you see the treatment for seminoma and non-seminomatous germ cell tumor. We all know seminoma is a you can say radiosensitive tumor. So for stage 1, okay, surgery you have already done. Okay, so either you will do follow-up or you can say surveillance. Okay, you don't do anything, or you give radiotherapy. I mean, you give radiotherapy to the lymph nodes, or you will give single dose carboplatin. For 2A and 2B, either you give radiotherapy or you give chemo, that is BEP3. Stage 2C and 3, you will give chemo BEP3. Okay, so these are the options. In stage 1 this is preferred, in stage 2 this is preferred, stage 3 is this. So the difference between seminoma and non-seminomatous germ cell tumor is non-seminomatous germ cell tumors are not radiosensitive. This radiation which we are giving to the lymph nodes, the retroperitoneal lymph nodes, para-aortic or intra-aortic cable. So non-seminomatous germ cell tumor, see stage 1, either surveillance. So instead of radiotherapy here, what you will do is you will go and surgically remove the lymph node. So that is known as retroperitoneal lymph node dissection. RPLND is retroperitoneal lymph node dissection. Or you will give 1 cycle of chemotherapy. BEP1 is single cycle. BEP3 means 3 cycles. Okay, so that is for stage 1. For 2A and 2B, either RPLND or BEP3. Yes, all this is after surgery. Okay, surgery is investigation in this case. High inguinal orchidectomy is the investigation of choice as well as the surgery in this case. Then only you will know not whether it is seminoma or non-seminoma. Otherwise, how will you know it is seminoma or non-seminoma? Because through the scrotum you are not doing any kind of biopsy or FNAC. So that's why first you do the surgery, and when you come to know it is seminoma or non-seminomatous, then you will decide the further treatment. 2C or 3, it is chemo, that is BP3. Okay, so can you see that treatment exactly same? In this case surveillance is preferred, in this case RPLND is preferred. So if you find it very difficult, just remember stage 1 surveillance, stage 2A, 2B radiotherapy, 2C, 3 chemo. And instead of radiotherapy, if it is non-seminomatous, it is retroperitoneal lymph node dissection. Okay, so this is the treatment of which cancer? It is the treatment of testicular cancer. BEP is bleomycin, etoposide, and P stands for platin, that is cisplatin, carboplatin. Okay, that is BEP, cisplatin or carboplatin. Okay, the last tumor we will see. So 3 tumors we have seen. The last we will see prostate cancer. Prostate cancer, which is here it is not taxanes. Here it is not taxanes. Okay, Rohit, it is platinum. Okay, paclitaxel and all we use in breast cancer, not in this case. Okay, it is cisplatin or carboplatin. Platinum compound, not taxane. Taxane and platins are different. Okay, so prostate cancer, mainly it arises from the peripheral zone of the prostate or the posterior lobe of the prostate. Investigation of choice is transrectal ultrasound guided biopsy. Okay, and when you see anatomically, you say that there are 5 lobes, but clinically when you palpate the prostate by the distal rectal examination, you will find 2 sides, right side and left side. Okay, so clinically we'll say 2 lobes, right and left, and we take 6 biopsy from each side, like 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. Okay, 6 from each side. Okay, no, total number of biopsies will take 12. Trust guided biopsy. Now to see the spread, we go for multi-parametric MRI. In case of when you have some suspicion that okay, the MRI is not telling you the correct thing, then you can go for PESMA PET, and bone scan can also be done if the patient is having symptoms, or if in the higher grades you can go for bone scan as well. Okay, now in this case you don't have to remember the whole staging, just remember the T staging. T1A and T1B are post TURP. Means you have done transurethral resection of prostate, which you do for BPH, and you will remove many small you can say the chips of the prostate. So when you send these chips for the histopathology examination, now the report comes that out of the specimen, this number of chips have the features of carcinoma. So if they say that tumor occupying less than 5% of tissue in specimen, that is T1A. T1B is tumor occupying more than 5% of the tissue in the specimen, that is T1B. So this is after TURP. We did not know that the patient has cancer. This we came to know later. T1C is, see, normally what we do, if I say investigation of choice for screening, because prostate cancer is very common, so for the screening what we do is we do the distal rectal examination and check the serum PSA. So on the distal rectal examination, if you find some nodule or if the PSA is increased, then you take the biopsy and then you come to know that there is tumor. Otherwise, prostate cancer generally does not cause any symptom which will bring the patient to you. Okay, so suppose distal rectal examination is normal but serum PSA was raised, and because of increased serum PSA the biopsy was done and the biopsy shows features of cancer. Okay, so T1C is biopsy done due to increase PSA. Okay, a PSA more than 3 is indication for biopsy. Okay, sometimes they write 2.5, but just remember more than 3 indication for biopsy. T2 is, now in T2 there is palpable nodule. When you do distal rectal examination, you will find palpable nodule. Palpable nodule. T2A is nodule involves half of one lobe. B is more than half of one lobe. C is both lobes. Like I said, there is right and left lobe clinically. T3A is when the tumor goes beyond capsule. This you will know on MRI. B is involves seminal vesicle. And T4 is adjacent organ involvement. Okay, so this is the T staging of CA prostate. Now we'll see the treatment. Okay, you need not know the exact and same to same treatment. The basic mota things which you should know is that if it is T1 or T2A, a very important thing in the management of prostate cancer in these initial stages is the life expectancy. Okay, if there is more than 10 years survival, more than 10 years survival, you can say if the patient age is less than 70 years. Okay, less than 70 years is the age. Then in these cases, you have options like you can do active surveillance. Gleason scoring is mostly a pathological type of score, but if you want, I'll tell you. Mainly a pathology thing. Okay, surgery people usually they don't go into this, but if you ask me, I'll tell you there is these days a new grading system. I'll tell you the new grading system. Okay, that will be the last thing. After the treatment, I'll tell you the Gleason score and then we'll end the class. It's already 8, so don't worry. Or we can go for radical prostatectomy. I'll write RP, active surveillance, or you can go for radiotherapy. These are the options. Active surveillance means you will not do any treatment, you will just repeat the PSA and repeat the biopsy. That is this. And if there is less than 10 years survival, that is more than 70 years, then wait and watch. Means you will not do anything. You will not do anything. T2B and T2C, more than 10 years survival, radical prostatectomy or radiotherapy. Less than 10 years, wait and watch. T3A, either radiotherapy or hormonal therapy or radical prostatectomy. This is hormonal therapy. you can say anti-testosterone type of treatment. T3B, T4 radiotherapy plus hormonal therapy. I'll tell you just the drugs. Hormonal therapy, enzalutamide, degarelix, this is GnRH antagonist, goserelin, abiraterone, or you can go for orchidectomy. Okay, so these are basically anti-testosterone. Okay, so that is a treatment. Now see, the last thing, 10-year survival means the same thing. Okay, if the patient is more than 70-year-old, then we say less than 10-year survival. Although we are nobody to predict the survival, but this is how the guidelines are made. I mean, if a patient of 75-year-old comes to me with this tumor or this tumor, I'll say nothing has to be done. Okay, nothing has to be done, because even if it is cancer, you will not do anything. It is wait and watch. Okay, so that is the meaning of 10-year or less than 10-year survival. Age, if age is less than 70 years, then you go for these things, because prostate cancer is a very slow growing cancer. So in a 80-year-old, they say that if the patient comes with cancer, you do the surgery, there are more chances that the patient will die because of the surgery or surgery related complication, as compared to if you let the patient live peacefully, then in the next 10 years he is not going to die because of prostate cancer. He will die because of some other thing, maybe MI or some hypertension or some diabetic complication. Okay, because prostate cancer is not a very aggressive cancer like the other cancers of the body. Suppose someone is diagnosed prostate cancer today, you can tell the patient you are not going to die because of the cancer in the next 10 years. Okay, so that's why if the patient is young, then there is benefit of doing those big surgeries or the radiation, because that will increase the survival. Okay, a 80-year-old patient will anyways die in the next 10 years, so that's why there is no point in doing some major treatment. So there is something like risk benefit ratio which you have to decide when you are treating an elderly patient. Okay, 98-year-old patient comes to you with some cancer. What is the point? Okay, so let the patient, there are high chances of this patient dying on the OT table rather than living with the tumor. Gleason score. Okay, so these days there is new grading system. Now people, they don't use the old type of Gleason's grade and the Gleason score. Now there is new grading system. Yes, no treatment for less than 10 years survival patient, like elderly patient more than 70 years, no treatment. Grade 1 score, may we write 3 plus 3, 6. It is only, this is pathology. Okay, this is pathology. Only individual discrete well formed gland. So basically, well formed gland, you will see the gland formation is there. Grade 2 score is 3 plus 4, 7. Predominantly well formed gland. With less composition of poorly formed gland. Okay, so this is grade 2. Grade 3 is 4 plus 3, 7. So that is basically, both the things are almost same. In this predominantly well-formed gland, in this case poorly formed glands are more. Four is 4 plus 4, 8. Okay, or you can write, sorry. In this case, you'll write predominantly poorly formed gland. This is predominantly well-formed gland. This is predominantly poorly formed gland. This is well-formed glands. 4 is only poorly formed gland. And 5 is 9 to 10 points lacks gland formation. Okay, now this is something which a pathologist maybe explain you better, but these days people they follow this new grading system. Okay, these days people they follow this new grading system. Previously there was a Gleason's grade. So there are two, because the cancer exhibit heterogeneity, so there were two areas which they individually give grade from 1 to 5, and then both the areas they combine, so then it becomes score from 2 to 10. Okay, so grade was 1 to 5, score was 2 to 10. But nowadays people they follow this new grading system. Grade 1 to 5, score is from 6 to 10. Yes, any other topic, Aishwarya, which you should do is, renal TB, okay, where there is putty kidney and, the gall fold ureter, the investigation, these things. BPH basically you see indication for surgery, and TUR syndrome. Renal TB, basically you need to see the putty kidney, cement kidney, and investigation. Treatment is nothing, it is ATT. Okay, BPH. Then torsion testis, I am sure you all know the treatment of torsion testis. Okay, if you have to do surgery in the initial 6 to 8 hours, and if the testis is healthy, you need to do orchidopexy on both the side. If the testis is gangrenous, you need to do orchidectomy on that side, and orchidopexy of the other side. Yes, putty kidney is just a image. In the previous year questions, it was just a X-ray image of putty kidney, and they asked what is the diagnosis. It was renal TB. Okay, BPH, it is arising from the median lobe or transitional zone. Treatment is basically mostly medical management, where you will give alpha blocker, like these days we give selective alpha 1A, tamsulosin, sildosin, and 5 alpha reductase inhibitor like dutasteride, finasteride. Indication for surgery is when there is acute retention, bilateral hydronephrosis, renal failure, recurrent UTI, severe symptoms Like there is a score, International Prostate Symptom Score more than 20, IPSS score more than 20, and failure of medical management. Causes of PUJ obstruction, I told you, the aperistaltic segment, I mean these are the causes of congenital PUJ obstruction: aperistaltic segment, high insertion of ureter on the pelvis, and abnormal lower pole vessel. Any topic in head and neck? Head and neck, so most of the important topics we have done. Okay, nothing much in head and neck. Okay, TURP syndrome is basically because of dilutional hyponatremia when you use a hypotonic fluid. Hypotonic fluid, so that's why the fluid of choice is 1.5% glycine, normal saline if bipolar cautery is used. Okay, so remember students, anything, any question, you are most welcome, okay, to ask. There is a DAMS exclusive club. In that you can tag me any kind of question. I am more than happy to answer your queries, any kind of controversy. You can ask me the questions, you can tag me. Most of the time I reply on the same day. If some busy schedule, maybe I might reply on the next day. Okay, so bladder outlet obstruction is, there are different causes, okay, like prostate, there is some urethral stricture. Okay, that is bladder outlet obstruction. Nothing as such you need to know in the bladder outlet obstruction topic. Okay, so thank you very much. I hope it was a kind of quick revision and maybe you have learned something new. Okay, I know the speed was fast, so if you have missed anything, you can you can see the recorded version and you can note it down in your notebooks about these things. Okay, so thank you very much, and my best wishes for your exam. Just surgery, most of the time they ask very simple questions, straightforward question. Okay, so stay focused, read the question twice before you mark. Image based questions are mostly easy. Don't think too much, just read the question once or twice and mark the answer. Most of the times the questions are easy. If they ask the clinical based question, lengthy questions, that will be more easy. So don't don't get scared by looking at the length of the question. Most of these lengthy questions are easy. Okay, so thank you very much. It was a great discussion and I wish you all the best. God bless you all. Any kind of question, query is most welcome. Okay, thank you. Good night.